update. And we will be having two sessions. First session is devoted to gastrointestinal tumors, genitorenal tumors, and the second to the gastrointestinal tumors. In the genitorenal tumors, we will be starting from the prostate cancer, will ascend to the bladder to the kidneys, and then we'll close the talk for the genitorenal session today, and we'll start with the gastrointestinal. So to start with the talk, may I invite Dr. Murli. He is a senior consultant, medical and hematological bone marrow transplant physician at Aster CMI Bengaluru. Dr. Aditya will be speaking on genomics and genetic testing for prostate cancer, the basics, the indications, implications, and future direction. So may I invite Dr. Murli to please start his talk without Dr. Murli, please.
Thank you, Dr. Sandeep. Thanks, Dr. Sachin Gupta, for organizing such a lovely event. And thanks, Horizon, for having me on board. At the outset, let me start by asking, I'm audible and my slides are visible, correct?
Yes, sir.
Yes, you are audible as well as visible.
So, I mean, it's been a while since I finished training, and during training, almost never did medical oncologists pay too much attention to prostate cancer. As a cancer itself, prostate cancer was never on top of our to-do list or an interesting list or what I can do better in this, because more often than not, this was a condition which was the domain of urologists. Almost always the first few initial lines of therapy used to be done, and finally when the patient did come to a medical oncologist, by the time patient was so washed out that no significant difference could be made to their lives. All of it changed with the advent of first line chemotherapy, and this came in about 7-8 years back, if I remember correctly. From then on, every year, every meeting, there has been one update on the other, and today we have finally arrived at a stage wherein prostate cancer has to be dealt with at the genomic and the genetic level. Only when we are able to do this right at the beginning would we ensure that we can get our patients the very best of outcomes. So finally, we are in an era where medical oncologist has again become the most important person in the treatment of patients with prostate cancer. So despite treatment options, outcomes remain poor for patients with prostate cancer. If we talk about 5-year survivals by stage, metastatic prostate cancer has a 5-year survival about 50% now. 50 years back, this was great news. I mean, when Dr. Charles Higgins found out the whole pathway for prostate cancer in terms of this being a hormone-driven cancer, at that time, 50% survival for stage 4 patients would have been a fantastic achievement. But in today's day and age, wherein we are talking about many advanced cancers in terms of turning them into chronic conditions, we definitely need to do better even with prostate cancer as well. So metastatic prostate cancer is biologically heterogeneous. In a multi-institution study, here we can see that about 20% of the patients have the Wnt pathway, about 50% of the patients have some problem with the PI3K pathway. I have been targeting the androgen receptor pathway, and this is why this treatment works in a significant majority of our metastatic prostate cancer patients. However, there will be about 23% of the patients who will have some sort of a mutation in the DNA repair pathways as well, which means it is very important to identify these subset of patients who can benefit from targeted therapies of this pathway. So mutations in the DNA repair pathway lead to genetic instability and drive tumor growth. I'm not going to be boring people about what is homologous recombination repair and non-homologous enjoining, but essentially what this slide wants to convey is that there are genes like ATM, BRCA1 and 2, PALB2, CHEK1-2, and RAD51 who play very important roles in homologous recombination repair, which is a key mechanism for the repair of double-stranded DNA breaks. Deficiencies in the HRR pathway proteins may increase the polyadenylyl ribose phosphates or the PARP inhibitor sensitivity. BRCA1 and 2 are by and large the most familiar ones, but many other proteins are associated with this pathway, and which is the reason why it's not enough if we test our patients only for BRCA1 and 2. Tumor development can arise from germline or from somatic gene alteration. The reason why this is important is there is always a doubt whether we test the tissue or whether we test the blood. Germline is basically something which is inherited from the patient and parent, and somatic is something which is seen predominantly in the tissue. So retrospective studies have found an association between germline mutations in BRCA and aggressive disease phenotype. And I think this is one of the first big take homes which I want to give for most of our people who have joined in. Any patient who's got a germline BRCA BRCA2 mutation, they are at a higher risk of presenting with a worse Gleason score, presenting with a higher tumor size, and with a higher chance of developing nodal involvement. So germline BRCA2 tumors are more likely to also show a pattern of intraductal carcinoma, which correlates with a poor prognosis. So already there is one more reason why we need to identify patients who might have any of the defects in this particular pathway. DNA repair alterations are enriched in metastatic versus localized prostate cancer. So the metastatic prostate cancer is a completely different beast, and in the DNA repair pathway, genomic alterations were identified in 27% of metastatic tumors versus 10% in primary tumors. So this is the second big point that we need to understand, which is that it is important to test patients who have metastatic disease, and the probability of finding anything relevant by testing patients for with localized prostate cancer may not be all that great. And this has got multiple implications which I will be dealing with in my later slides. So evidence suggests that mutations in the HRR pathway are early driver mutations of prostate cancer, and HRR identified in MASH prostate identified early and stable through the evolution to metastatic prostate cancer. Other genomic defects are dynamic through evolution of metastatic CRPC. So HRR mutations are early driver mutations, and which supports consideration of archival tissue for assessment of gene alterations. So what all are the genes to be tested? I'm not going to be boring you all with the panels, and this is not an MCQ to remember the names of all the genes, but essentially it's important to check the HRR panel. And most of the labs in India in the last couple of years have a standardized HRR panel, which does give fairly satisfactory reports. At what point in the patient pathway should HRR gene testing take place? Now, this is a slide which I'll spend some time on because it's very important. The pros and cons are as follows. If we want to check a patient at the primary level or at the adjuvant or at the biochemical recurrence level, tumor tissue will be available from a diagnostic biopsy or a surgery. But at this stage, there would be no role for HRR mutation testing in guiding treatment decisions. Potential biopsy of metastatic sites in de novo setting is possible, but again, there would be no immediate role for HRR mutation testing in guiding treatment decisions. It is very important to test at the first line CRPC setting when the patient becomes castrate resistant. Testing at this point would immediately identify HRR mutation patients potentially eligible for a PARP inhibitor like olaparib, but unfortunately, archival tissue may not be readily available because of the extended duration of time over here. So by this point, sourcing that sample material from a diagnostic biopsy or surgery could be a huge challenge. So there are pros and cons at both, but in my own clinical day-to-day practice, I am still not comfortable in recommending HRR testing at the early stage or even at the HSPC stage. Essentially, consideration of testing or the discussion happens only at the CRPC stage. So NCCN guidelines acknowledges the need to consider tumor HRR mutations and MSI MMR testing for patients with regionally low advanced or metastatic prostate cancer. The Philadelphia Prostate Cancer Consensus Conference held in 2019 recommends large germline panels and somatic testing for metastatic prostate cancer patients, but germline testing is also recommended for patients with a family history suggestive of hereditary prostate cancer. Very significantly, the APCCC 2019 consensus, according to this, about a vast majority of the panelists recommended genetic counseling. And they recommend external panel testing for germline DNA in patients with prostate cancer, including the whole HRR panel. So the big takeaway from this slide is that it's not enough if we just test for BRCA1 and 2. We need to also test for the whole HRR panel. So I think that this is one slide which is very important. Probably the most important part of my presentation is the American Urological Association, ASTRO, SEO, and ESMO, which have updated their recommendations for consideration of genomic testing. So as per the 2020 guideline, in patients with hormone naive prostate cancer metastatic disease, regardless of age and family history, clinicians should offer genetic counseling and germline testing. In patients with CRPC, clinicians should offer germline and somatic tumor genetic testing to identify the DNA repair deficiencies. So the ESMO 2020 guidelines usually say that the tissue-based molecular assays may be used in conjunction with clinical pathological factors. Germline testing for BRCA2 and other DDR genes associated with cancer disposition syndromes is recommended in patients with family history of cancer and should be considered in all patients with metastatic prostate cancer. In patients with CRPC, the whole HRR panel mutation testing could be considered. Patients with pathogenic mutations in cancer risk genes identified through tumor testing should be referred for germline testing and genetic counseling. So even the EUA 2020 guideline recommends molecular testing to take place early or at least as soon as the patient becomes castration resistant. Genetic sequence of the primary tumor, the ctDNA on the liquid biopsy, or the use of fresh tissue biopsies of metastatic spread should be considered. So different molecular diagnostic strategies can be considered to detect different types of mutations, but there will be pros and cons. I think the most important thing is that if we want to use primary tumor for testing, archival tissues do provide an option for testing, and this is usually the preferred approach to identify patients with HRR mutations. The issue is that there will always be some in-tumor genetic heterogeneity, and we might end up missing the genetic mutation. The biggest problem is obtaining samples from metastatic site, and sample inadequacy may lead to a failure in about 30% of the cases. On the other hand, if you want to do the liquid biopsy, the sample obviously is very easy to obtain. However, the testing is limited by the availability of the adequate amount of circulating tumor DNA. So highly sensitive tests are required, and it's not yet come of age. Profound was the pivotal PARP inhibitor trial of olaparib in prostate cancer, and this slide basically shows that the reason for test failures were essentially either archival samples where we are not able to get, and the sensitivity of the newer samples were quite low. So these factors highlight the critical importance of selecting high quality samples and optimization of tissue collection to improve NGS testing and success rates. PARP inhibitors obviously is very important. I'm not going to be going into this because my talk is coming to an end, but this is going to be a very important treatment option for patients with any of the deficiencies in the HRR pathway. BRCA2, although is the most common HRR pathway mutated gene in prostate cancer, about 50% of the patients are derived from germline origin, which means that there can be mutations in the ATM gene, in the CDK12 gene. So it is very important to check the whole HRR gamut of mutations. Matched pair sample analysis of blood and advanced cancer tumor tissues is something which is going to improve our sensitivity, and this strongly argues for performing tumor genomic analysis in patients with advanced prostate cancer. So it's very important for genetic counseling to be done at one or more points in the process. Pre-test genetic counseling and informed consent is absolutely mandatory for all of our patients before we recommend for these tests. Tumor tissue for HRR mutation testing is the preferred approach, and then these are the ways in which the pathology process happens, the DNA extraction happens. Essentially, all of this is a NGS based panel. it's very important to have a MDT to discuss and decide how we are going to go about doing the HRR mutation testing. What is the site from which we will do? Do we use the archival tissue, or do we use a biopsy from a metastatic site? So all of these people should be a part of our molecular tumor boards. Although this does not happen in every hospital, but this is something that we should try and aspire for. Tumor testing from bone samples can always be challenging, and this is not something that we would want to do. So to sort of summarize my talk, prostate cancer is associated with molecular heterogeneity. NCCN guidelines acknowledges the need to consider tumor HRR mutations and MSI mutation testing. Tumor tissue testing is still considered the gold standard. However, tissue, germline, and circulating tumor DNA testing all have different advantages and disadvantages. So an algorithm for the use of more than one diagnostic option is likely to be needed in prostate cancer. In metastatic CRPC, use of archival samples can be successful. ctDNA testing can be considered for both germline as well as somatic mutations, but careful attention has to be paid to potential false positive and false negatives. Identifying family history and cascade testing can help identify at-risk patients. However, not all HRR mutation carriers have a family history of prostate cancer. Thank you all for a patient listening, and I'm happy to take any questions. Thank you.
Thank you, Dr. Murli. That was an excellent talk, and thank you for staying well in time. I think let's complete the prostate session by involving Dr. Venugopal Araju, who is the next speaker, and he will be speaking upon treatment sequencing and recent advances in the CRPC. Once we complete this talk, then probably we can ask some questions. I would request you to stay back if there are any audience questions or if there is any question from the faculty. Thanks once again for your detailed lecture, and I request now Dr. Venugopal Araju, who is a consultant medical oncologist at Apollo Health City, Hyderabad, to start his talk, which is on treatment sequencing and recent advances in CRPC. Over to you, Dr. Araju.
Yeah, hello. Very good evening to all. So I'll be talking on recent treatment sequencing and recent advances in CRPC. So basically, as we know, prostate cancer is comprised of multiple disease states. So basically, today's talk, our focus will be on CRPC, especially metastatic CRPC. So basically, coming to the workup, so imaging studies which are positive for metastasis in the CRPC, so go ahead with metastatic lesion biopsy, tumor testing for MSI status, and now HRR mutation alterations. These testings will be helping us in guiding the treatments. And wherever feasible, just go ahead and do the tumor mutational burden testing as well. So these are all the FDA approval timeline of drugs in metastatic CRPC, which includes docetaxel, cabazitaxel, abiraterone, enzalutamide, radium-223, pembro for MSI high tumors, olaparib, and rucaparib. So these treatment options will be just little discussing the coming slides. So basically, the initial treatment will determine the further treatments. So those patients with no prior docetaxel and no prior novel hormonal therapy exposures in CRPC, the preferred regimens will be abiraterone, docetaxel, enzalutamide. And those patients who have got prior docetaxel with no prior novel hormone therapy, the preferred regimens will be obviously abiraterone, enzalutamide, and the patients who have got prior novel hormone therapy with no prior docetaxel exposure, the preferred regimens are docetaxel, and for HRR mutated category 1 recommendation, olaparib and rucaparib only for the BRCA mutated patients. So those patients who have got prior docetaxel and prior novel hormone therapy, so these are all the regimens which we have in our toolkit: cabazitaxel, docetaxel, olaparib, and pembro for MSI high tumors, TMB, more than 10 mutations tumors. So if you look at the chart, yeah, the treatment options, metastatic CRPC, they are primarily based on phase 3 RCT evidence. The docetaxel for us, the evidence comes from the TAX 3 to 7, where it has given overall survival benefit of around 2.9 months when compared to mitoxantrone hazards being 0.76. And in the pre-docetaxel setting, we have the evidence for abiraterone from COU 30 trial, where abiraterone, when compared to the placebo, it has given, when compared to the prednisolone alone, it has given overall survival benefit of around 4.5 months. And the enzalutamide, the evidence comes from previal study in the pre-docetaxel setting, and where the overall survival benefit is close to 4 months, hazards being 0.77. And pre or post-docetaxel setting, we have the approval for olaparib from the profound data. Basically, HRR mutated metastatic CRPC, pre or post-docetaxel setting with progression on one prior NHA for metastatic prostate cancer or CRPC as such. So where olaparib has given us overall survival benefit of 4.4 months in the cohort A, that is basically BRCA1, BRCA2, ATM alterations. And post-docetaxel setting, we have the approval for enzalutamide, abiraterone, rucaparib as well, cabazitaxel, radium-223. So where enzalutamide, abiraterone, roughly the evidence tells us that we have got the overall survival benefit around close to 4.5 months. Rucaparib, HRR mutated metastatic CRPC post-docetaxel setting with progression on 1 or 2 prior novel hormone therapies for mCRPC. The rucaparib is approved for only BRCA1, BRCA2 mutations. And radium-223, definitely, yes, we have some role. Cabazitaxel, definitely after docetaxel exposure. So we know that several large retrospective studies, they have found an association between BRCA mutation and aggressive disease and rapid progression to the metastatic disease. So this has been already detailedly discussed by Dr. Aditya. Genetic testing, germline or somatic. It is prudent to go for co-testing for maximizing the diagnostic yields, and germline testing allows for early family member screening and counseling. And thirdly, there is no difference in responses or outcomes of the patient with germline or somatic mutations when treated with the PARP inhibitors. And when it comes to the optimal tissue, again, it was detailedly discussed, so I'll be skipping off this slide. So coming to the evidence of the olaparib from the phase 3 profound data, where they have included patients with metastatic CRPC and progression on prior NHA, harboring the gene alterations with a role in HRR. So basically, they have divided into 2 cohorts. One is cohort A, cohort B. Cohort A comprises of BRCA1, BRCA2 ATM gene alterations, whereas cohort B comprises of other HRR alterations like BRIP1, BOD1, CDK1, 2, CHEK1, CHEK2, PALB2, etc. So they were randomized to receive olaparib versus physician's choice. So this was the cohort A and cohort B, which comprised of HRR 15 gene panel, and the qualifying HRR gene alterations was identified by the prospective tissue testing using the 15 panel of genes. So profound met its primary endpoint in terms of median PFS with olaparib 7.39 months versus 3.55 months with the physician choice, hazards ratio being 0.34, and p-value is significant. So basically, olaparib has reduced the risk of progression or death by around 66% versus the physician choice in the cohort A, that is in alterations with BRCA1, BRCA2 ATM genetic alterations. And when you look at the OS at the interim analysis, olaparib had a favorable trend in overall survival in these cohort A patients, BRCA1, BRCA2 ATM gene alterations, despite more than 80% crossover for the eligible patients. So when you look at the median overall survival, it's 18.5 months versus 15 months, hazards again being 0.64 months. So when you look at cohort A plus B, the whole ITT population, radiographic PFS, 5.8 months versus 3.5 months, roughly the median difference in PFS with olaparib was 2.3 months. And this is the final OS, BRCA1, BRCA2 ATM alterations, OS hazards being 0.69 with olaparib. When you look at the cohort A plus B, whole intent to treatment population, interim analysis, olaparib showed definitely a favorable trend in A plus B cohort as well, despite more than 80% crossover for the eligible patients. So when you look at the subgroup analysis, not all the mutations benefit. So if you look at the genetic alterations plot here, BRCA1 had the 0.41 hazards, BRCA2 has got the least 0.21 hazards, ATM almost close to unity 1.04. So not all the genetic alterations benefit. So that's the reason BRCA1, BRCA2 is the most beneficiary group with olaparib. That's what we can conclude. And the recent the Propel data from ASCO, the recent ASCO. So it is a global randomized double-blind phase 3 trial. Basically, this trial answers, tries to answer the question whether we can do better than anything above and over the abiraterone. So olaparib plus abiraterone was tried compared to the abiraterone alone. The patient population is first-line metastatic CRPC. Docetaxel was allowed at hormone-sensitive prostate cancer stage. No prior abiraterone exposure. Other NHAs allowed if stopped 12 months or more than 12 months prior to enrollment, ongoing ADT, and ECOG 01. So they were randomized to receive olaparib plus abiraterone versus abiraterone. Primary endpoint is PFS, secondary endpoint is OS. So when you look at the PFS curves here, with olaparib plus abiraterone, the PFS is 24.8 months versus 16.6 months with abiraterone alone, hazards being 0.66. So that is significantly improved radiographic PFS survivals with a combination olaparib plus abiraterone compared to abiraterone alone by around 8.2 months. And when you look at, this was by the investigator assessment, when you look at the central review, the same way 27 months versus 16 months of PFS, hazards being 0.61, around close to 11 months improvement in the PFS with the combination of olaparib plus abiraterone. Overall survival data, definitely long-term OS data is avoided. Only 28.6% maturity. Trend towards improved OS is seen with olaparib plus abiraterone, but definitely we will wait for the matured OS data, final OS data. And when you look at the overall safety profile, so a relatively small increase in the discontinuations for olaparib versus placebo. Grade 3 or more than grade 3 adverse events with the combinations are in the range of 47% versus 38%, and leading to the dose interruptions with the combination is around olaparib discontinuations are 44% versus 25% respectively in the combination versus abiraterone alone. Those reductions requirements 20% versus 5%. Those discontinuations of olaparib 13% versus 7.8%. Discontinuation of abiraterone 8% versus 8%. And notably, no MDS or no AML reports were reported. And most common adverse events, AE profile was consistent with the known toxicity profiles for the individual drugs. As we know, olaparib, anemia, insomnia, fatigue, these are all quite manageable side effects. And these are the seen, as we see here, more consistent with the known toxicity profiles. The most important and interesting point is data suggests that PFS benefit of olaparib plus abiraterone is independent of the HRR biomarker status. That is, whether there is presence of alterations or no alterations, all the patients have got the PFS benefit at the initial analysis as well as the final analysis. So that is the best part of the trial. So next, coming to the magnitude trial, again presented at ASCO, recent ASCO, randomized double-blind placebo control study, prospectively selected biomarker cohorts designed to test HRR biomarker positive as well as HRR biomarker negative. So again, the patients were first-line metastatic CRPC, where 4 months or less than 4 months prior, abiraterone was allowed for metastatic CRPC, ECOG PS01, and the stratifications were prior taxane-based chemo for CSPC, prior androgen receptor inhibitor for non-metastatic CRPC or CSPC, and the most important is HRR biomarker positive cohort only, BRCA1 or 2 versus other genetic alterations. So here again, biomarker panel included ATM, BRCA1, BRCA2, BRIP1, CDK12, and other alterations. So where basically the 400 patients were biomarker positive, 600 patients were biomarker negative. They were randomized to receive niraparib plus abiraterone versus placebo. The primary endpoint was PFS, secondary endpoints OS. So basically biomarker negative pre-specified early futility analysis, no benefit of niraparib plus abiraterone in these biomarker negative patients at all. When it comes to the biomarker positive cohorts, so these were the baseline characteristics. So when you look at the BRCA1, BRCA2 mutated patients, the primary endpoint was, when you look at the primary endpoint PFS, by central review, it is around 16.6 months with the combination niraparib plus abiraterone versus 10.9 months, that is hazards being 0.53, and even by investigator assessment, hazards being 0.50. So definitely in BRCA1, BRCA2 mutated patients have got significant improvement in terms of the PFS, reduces the risk of progression or death by around 47% with the combination when compared to the abiraterone alone. And when you look at all HRR biomarker positive, the combination significantly reduced the risk of progression by around 27%, hazards being 0.73. So the pre-specified subgroup analysis of PFS showed the consistency of the effect in the all HRR biomarker positive patients. So when you look at the time to cytotoxic chemotherapy across all gene alterations, the combination provided a consistent magnitude of improvement that is more than 40% across the evaluated groups in terms of the time to cytotoxic chemotherapies. And in the similar way, time to symptomatic progression across gene alterations, the benefit was seen with combination over single agent abiraterone by more than 30% in terms of the time to symptomatic progression. And when you look at the overall survival, definitely the overall survival data is immature. First interim analysis with only median follow-up of 18.6 months. But with the available data, when they looked at pre-specified OS multivariate analysis, overall survival HR hazards being 0.76 with the combination nira plus abiraterone. And in the similar way, combination nearly doubles the median time to PSA progression with close to 40% improvement, and the overall response rates definitely near doubling of the ORRs in the combination niraparib plus abiraterone compared to the single agent abiraterone in all biomarker positive as well as the BRCA1, BRCA2 mutated positive patients. So the summary of the treatment emergent adverse events. So definitely the most common adverse events leading to the dose reduction in the nira plus abiraterone were anemia and thrombocytopenia, as we know the class side effect profile, and median relative dose intensity was 99% in the nira plus abiraterone group. So the adverse events consistent with the known safety profile for each therapy, as we know, hematological, cardiovascular, respectively for the niraparib plus abiraterone. So one word about the lutetium therapy in CRPC. Patients with PSMA positive MCRPC previously treated with both androgen receptor pathway inhibitors and 1 or 2 taxane regimens, they were randomized to receive lutetium or standard of care, where the study has shown benefit in terms of overall survival in all randomized patients, 15.3 months of median OS with lutetium therapy versus 11 months, hazards being 0.62. So OS and PFS are generally consistent across all pre-specified subgroups. So definitely lutetium has a role. So these are the select and combination strategies and trials, ongoing trials in metastatic CRPC now. The take home being metastatic CRPC, we have docetaxel, we have abiraterone and enzalutamide, but in patients with mutated HRR, single agent, that is when the patient has BRCA2, BRCA1 mutations, we have a role for olaparib plus rucaparib, and non-BRCA, we are still unclear, but again, when the PALB2 genetic alteration is seen in CRPC, we have a role for olaparib. And when it comes to the combination PARP inhibitors plus abiraterone, not approved as yet, but PROPEL gives the evidence for olaparib for all, irrespective of the HRR mutational status, positive or negative, and magnitude gives us the evidence for the niraparib, although at lower doses in combination with the abiraterone. Thank you.
Yeah, thank you, Dr. Venugopal. That was an excellent discussion about the flow of treatment in the CRPC setting. So, we have completed 2 sessions. One was with the genetic testing in the prostate cancer that was dwelled upon by Dr. Burli, and now you have completed this prostate session. So, if I may ask from Dr. Burli, so upfront setting, metastatic hormone-sensitive prostate cancer, would you be doing a biopsy or the genetic testing from the primary tissue, or you will be doing a biopsy from the metastatic site?
See, thanks for involving me, Dr. Batra, over here. So, this actually depends upon the need for the tissue. So, at a HSPC stage, I would not recommend doing a genetic testing at all. More at a CRPC or a hormone resistant phase is when we would want to do. In terms of where to do a biopsy, obviously the primary site would be the best possible site. In case we cannot get it from the primary, then we would want to try and do it from the liver or the nodal site, wherever it goes.
Dr. Murli, if the patient, usually if it is 12 months, 18 months, the patient turns HRPC. So you already have your wax blocks containing the archival tissue from
Correct.
the primary. Now I
Correct.
need, it will be sufficient for you for testing, because if it is sufficient, then probably at the time of diagnosis itself, you could have done the testing, or you will go for a biopsy, next biopsy from a metastatic site. Is there a discordance between the genetic testing between the primary site and the metastatic?
So answer to all three questions are like this. So first thing is, in 70% of the cases, the primary tissue is good enough or the archival tissue is good enough. To answer the second one question as to why we would not recommend doing it at the earlier stage itself, that's probably because if the patient is positive, there is no data for us to try and implement a treatment decision based upon the test result, which is the reason why if we cannot act on the result of a test, why do the test is the debate over there. And the third thing is whether to do it from a metastatic and what is the discordance rate. It's obviously preferable to do it from a metastatic site when the patient has developed distant mets, and there will be a discordance rate. There will definitely be a discordance due to tumor heterogeneity, and that would be about 30% discordance.
30% discordance. That's a quite high figure, sir. Okay, so we got the answer. So let's go back to Dr. Venugopal, sir. Uh, do you think, like we have maintenance strategies in the first line, second line, platinum sensitive ovarian cancers, of any maintenance role of PARP inhibitor in the metastatic hormone sensitive prostate cancer, which has got a BRCA1, BRCA2, or HRR mutation status?
The top maintenance, sir.
PARP maintenance, olaparib, rucaparib, in the BRCA mutated or HRR mutated prostate cancers. Do you think anything like that is very much successful in the ovarian cancers with the Palomar trials, with the Solo 1-2 trials? Do you think is such strategy going to take place in near future for the prostate cancer patients whom we have started on hormone therapy? You showed a trial in which abiraterone was combined with olaparib.
Yes.
Do you think in future of BRCA mutated patients they will be eligible for a maintenance olaparib with the hormone therapy in the first line itself?
Yeah. So as of now, sir, we don't have the data to comment on that, I feel, but definitely yes. So irrespective, as we were discussing about the data from Propel, where the olaparib disturbance is from my side.
No, I
Yeah.
don't think
Yeah. So as of now, we don't have the robust data, but at least in the positive biomarker positive patients like HR with HRR genetic alterations, I think in the coming days we may find a role, sir. But as of now, no.
Thank you. I think we conclude this prostate cancer. I thank one again Dr. Aditya and Dr. Venugopal for painstakingly making the presentations. We now move on to the session for the bladder cancers, which will be a talk on the neoadjuvant and adjuvant chemotherapy for locally advanced bladder cancer. And to deliver this talk, we have a very eminent medical oncologist from North India, Dr. Vineet Talwar, who is the Director of Medical Oncology at Rajiv Gandhi Cancer Institute, Delhi. And I would request him to please start his talk. And once we are done with the bladder cancer talk, then probably we take up the questions for the same committee. Over to you, Dr. Talwar. Is Dr. Talwar there? Pooja? I do not get.
Hello,
Dr. Talwal,
good
are you
evening.
there?
So today we are going to discuss the neoadjuvant and
Yo, Rahul,
adjuvant
can we hear you? Can you
immunotherapy
welcome, Dr.
drugs
Talwal?
which are being used in muscle invasive CA urinary bladder. So this is the general schema which you have as far as the neoadjuvant therapy is concerned for MIBC. You have patients who are eligible for cisplatin-based therapy. These patients undergo gemcitabine and cisplatin combination, or they go for dose-dense MVAC and then subsequently followed by cystectomy. Now, what happens to those patients who are ineligible for cisplatin-based? Well, these patients can be given carboplatin in certain situations, or sometimes these patients can be subjected to immunotherapy drugs, which I'm going to discuss with you just now. So when we talk of the immunotherapy drugs in this subset of patients, the rationale is that there is an extrapolation from the immuno-oncology success in the metastatic urothelial cancer setting. And of course, you have the patients who are cisplatin eligible, they require surgery for localized disease. So the agents which I'm going to discuss are basically atezolizumab, pembrolizumab, and nivolumab. And the original articles are the ones which are in the single immuno-oncology drug set, and also in the immuno-oncology IO combo set. So you have singlets and you have doublets. So in the single agent IO drugs, this is the PURE-01 phase 2 trial. So this was the preliminary activity of neoadjuvant pembrolizumab in patients with MIBC, and they are the ones with the variant histologies. The schema was such that patients with predominant variant histology of bladder tumors, they are defined as involving more than 50% of the tumor specimens and are typically excluded from the clinical trials in these patients. The efficacy of chemotherapy is limited. So the inclusion criteria in this was T2 high grade, T2 to T4A, node negative, and non-metastatic. And later on, this study was amended to include predominantly the variant histologies. So 114 patients were there with predominant BH, and 3 cycles of pembrolizumab was given. Then that was followed by the radical cystectomy. And the results were the patient achieved T0 in about 10 to 54%, and these patients were the ones who had PDL1 of more than 10%. Those patients who did not express PDL1, it was 13%. So there was a stark difference between the outcomes in those patients who had a PDL1 positivity vis-a-vis the patients who did not have. And there was another entity, that is the tumor mutational burden. It was seen that there was no linear association of the T0 achievement with TMB. However, the variants which were there, that is the squamous cell and the lymphoepithelioma, like they found that these were the patients who had very good response with the IO drugs. And it was more in those patients who had PDL1 of more than 10. So there was a role of neoadjuvant pembrolizumab in variant histologies, and surgical responses could be compared as compared to the conventional histologies. And it was seen that 42% of patients had a PAT-CR, and in this, PDL1 was a very big predictor. The higher the PDL1, the more was the response. TMB was, of course, heterogeneous. Suffice to say that if the TMB copies were more than 10, then probably there was a benefit of IO drugs in this setting. Coming to the next trial, that is the abacus trial. The schema of this trial was, this was in a phase 2 multi-center study which enrolled about 100 patients. And these were the patients who were awaiting radical cystectomy. Again, T4 T2 to T4A, N0. And in this, atezolizumab was given 1200 milligrams every 3 weekly. And this was 2 cycles. And the primary endpoint was the achievement of PATH-CR. And the results were that 31% of patients had PCR in these subset groups, and 30 patients had a sequential imaging and radiologically measurable disease at baseline, and 23% of these patients radiologically responded. So you had a PATH-CR with a radiological response in these patients. So grade 3-4 toxicities were there. These were because of the atezolizumab. This was seen in about 12% of patients. But a meaningful PCR was seen at the interim analysis. Final analysis has yet to come now. So pre-existing activate T cells correlate with outcome, and tissue repair genes express more in responding patients. That was again the basis for inclusion of atezolizumab in this study. So the question is, does achieving HCR with neoadjuvant PD-L1 or PD-1 blockade correlate with improved long-term outcomes? Well, you can see in this graph, the probability of survival increases in patients who have a PATH-CR, and this you can see over a period of 18 months that there is a difference and the graphs are separating. And those patients who have a PATH-CR, they're the ones who do better as far as the survival is concerned, as compared to patients who don't have a PCR. So this could be a surrogate level endpoint in these patients who are given neoadjuvant IO drugs. Coming to the doublet trials, the early phase 3 neoadjuvant doublet trials, the first one is the combination of durvalumab and tremelimumab. These were given as 2 cycles. There were 2 cohorts. I would not go much into the detail. Suffice to say that durvalumab was given 1500 milligram and tremelimumab was 75 milligram. And cohort 1 included the tremelimumab of 75 milligram. Cohort 2 included the tremelimumab of 300 milligrams. And both were given from week 1 to week 5, after which cystectomy was done, and that it was subjected to follow-up. And it was found that the response rate in association with adverse events or variant histology were based on the grade of the immune-related adverse events. And there was a pathological response, as you can see in these patients in the bar charts which have been shown. So the doublet was active. The second one is the Nabucco trial, in which combination of 2 IO drugs, that is ipilimumab and nivolumab is there, that is a CTLA-4 plus PD-1 inhibitor. And they again had 2 cohorts. The first cohort was cohort 1, in which ipilimumab was given as 3 milligram per kg. Nivo was given as 1 milligram per kg. So initially, in the first 3 weeks, ipilimumab was given alone, and subsequently it was given in combination. And then further on, it was only nivolumab till about 11 weeks or till the cystectomy was done. In the second cohort, that is cohort 2, it was again of 2 types, in which the dose of ipilimumab and nivolumab were different. In cohort A, ipilimumab was 3 milligram per kg, and in cohort B, ipilimumab was 1 milligram per kg. And in cohort A, the dose of nivolumab was 1 milligram, and in cohort B, it was 3 milligram. So a jugglery was done as to which dose and which drug was the best suited for the patients who underwent cystectomy. And it was found that in cohort 2B, in which the ipilimumab dose was only 1 milligram, they were the ones who had done the least. So the others in which the dose of ipilimumab was 3 milligram, that was the best suited, whether it was cohort 1, cohort 2A. And the final results of this have yet to come. But then there is an indication that the dose of ipilimumab should be 3 milligram to get the best benefit. Because even with the variation of dose of nivolumab for 1 milligram or 3 milligrams, it did not make a dent on the T0, that is the PATH-CR. And as you can see, there is a lot of heterogeneity when you talk of neoadjuvant immuno-oncology drugs. If you give as a singlet or you give as a doublet, you find that when you give pembrolizumab, there is a PCR of 42%. If you give atezolizumab, PCR is 29%. The discordance may be the selection of patients and the responses of the drugs, but the final word has again to be told. Coming to the adjuvant trials, now switching gears from neoadjuvant to the adjuvant trials. Again, the rationale why to give adjuvant in this, the problem is that if you do radical cystectomy alone in those patients who are T3, T4 or node positive, you have a relapse-free survival of just 35 to 40% and a 5-year overall survival of dismal 10 to 40%. So problem is that these patients there's something else which has to be done. There is an unmet need. And this was the schema. The patients who were included, they were high risk features, which T3 or T4 or node positive was there. Sometimes these patients were cisplatin ineligible. Sometimes in these patients already had received neoadjuvant therapy. So the question was how long to give. The trials were subsequently scheduled for 1 year as an adjuvant. So this is the schema here, which I've just discussed with you. In high-risk patients, high-risk disease at cystectomy. So these trials are the Checkmate 274 trial, which included nivolumab, IMvigor 010 that included atezolizumab, and there's another trial that is the Alliance trial or the Ambassador trial, which has adjuvant pembrolizumab, which is already going. The interim results of these studies have been shown, which I'm just going to discuss with you. The first is the Checkmate 274 trial, and this is the schema of Checkmate 274. In this, the patients were those who had received neoadjuvant cisplatin-based chemotherapy, or those patients who did not receive or were ineligible or had refused adjuvant cisplatin chemotherapy. So you had a cohort of patients who had received chemotherapy, then subjected to cystectomy, and you had a patients who received chemotherapy and did not want to take adjuvant cisplatin. In these patients, nivolumab was given as 240 milligrams every 2 weekly versus a placebo. So this was a placebo-controlled trial, and the treatment was continued up to 1 year of adjuvant therapy. The primary endpoints in this study was the disease-free survival in the intent to treat population, and the secondary endpoints were, of course, the recurrence-free survival, the quality of life indices, and also the toxicity profile. And these were the baseline characteristics, which you can see they are very well matched with the nivolumab and placebo. All these patients were in good PS, and most of these tumors were from the urinary bladder origin. That is about 80% of these tumors, and about 45% of patients had received neoadjuvant cisplatin-based chemotherapy. So these were the results. You see the disease-free survival at 12 months. You see there is a stark difference: 62.8% patients versus 46.6% patients. But again, when you sift out those patients who are PD-L1 more than 1% positive, you find that the graph plays out further, and it is much more towards nivolumab versus the placebo. So nivolumab prolonged the disease-free survival versus placebo in most subgroups of the intent to treat population, except for patients who had initial tumor in the renal pelvis. This was the conclusion of this, and you can see the quality of life indices. And most common grade 3 TRAs were of diarrhea, colitis, pneumonitis, and there was no quality of life indices deterioration with nivolumab versus placebo. That is, they were almost comparable. There were 2 deaths due to pneumonitis in the nivolumab arm. So in summary, it was a placebo-controlled trial. It included upper tract patients also, 21% times. The DFS was 21 months. The overall survival at present is not mature, and there was no deterioration in the quality of life indices. And PDL1 positive tumors, the DFS was 67 versus 46%. So this was a positive trial. The next trial is the IMvigor 010 trial. And again, the same group of patients who had high risk CA urinary bladder and who had undergone radical cystectomy or nephroureterectomy with lymph node dissection. And no radiation or adjuvant chemotherapy was given in these patients. The primary endpoint was the disease-free survival, and the secondary endpoint was the overall survival in these patients. And we find here that this study was a negative study because the fact that when you see the final results, the 18 months disease-free survival rate was 51 versus 49, and it was not statistically significant. And although the DFS was 19.4 months, but it could not achieve the primary endpoints of the study. So two studies, one is with nivolumab, the other one is with atezolizumab. Atezo is a negative study, nivo is a positive study. There's another study, that is the third study, that is the ambassador study, which is ongoing again with the pembrolizumab 200 milligram every 3 weekly into 1 year versus observation. And they were stratified by the PDL1 status, previous neoadjuvant chemotherapy, and pathological state, that is T2 to T4 N0, with microscopic invasive margins. The primary endpoint in this again is the overall survival and the disease-free survival. And secondary endpoints, they're trying to find out whether there's any correlation with the PDL1 positivity or not. So there are no interim reports yet, but this trial again is very exciting because this is the third immuno-oncology drug which is being used as an adjuvant, as is the natural history of any immuno-oncology drug. So this remains to be seen. So to conclude, I think we have 2 or 3 trials which are there in the neoadjuvant immuno-oncology setting, which was never there earlier. And we have 3 trials in the adjuvant setting, out of which one has shown interim results, which is a positive trial, that is the one with nivolumab. The second one with atezolizumab is a negative trial, and the third one with pembrolizumab, the results are awaited. So exciting times for us, and I think we have more drugs in our armamentarium in those patients who are cisplatin ineligible or who don't want to take chemotherapy because of whatever reasons, whether it is comorbidities or other things. So I think I will stop here, and I thank you for the patient hearing. Thank you very much.
Thank you, Dr. Talwar, for that exhaustive discussion about the role of immunotherapy in the bladder cancer in the neoadjuvant and adjuvant setting. We are well on time, and I must congratulate the previous speakers for sticking to their schedule and getting an elaborate discussion done. Now we have the next session, which is a sponsored session by Pfizer, which is on the first line maintenance in the treatment of metastatic urothelial carcinoma with clinical trials clinical trials to clinical practice. And for this, we have an excellent speaker, Dr. Vamshi Krishna. He is Director and Head of Medical Oncology and Hematology at Institute of Oncology, AIG Hospitals, Hyderabad. It is love to hear him, and and you also fall in love with him when you debate with him in many meetings. So I would request Dr. Vamshi to please start his talk, and then probably we can discuss something more about the bladder cancer and the course of time. Over to you, Dr. Vamshi. Yeah,
good evening, everyone. I think I'm audible. After 2 years, we are still asking each other, are you audible and are you visible? Just give me a second. Yeah. I hope my slides are visible.
This is the first product slide.
Yes. Okay. Absolutely. So thank you, Dr. Sandeep, and thanks to the organizers for giving me this chance. What I will be doing in the next there's a lot of disturbance in the better. So what I'll be doing, this is a sponsored session, and these are not my slides. I will be presenting this data of the Bavencio, that is the avelumab maintenance, in patients with locally advanced or metastatic urothelial carcinoma that has not progressed after platinum-containing chemotherapy. We'll see why this trial was important, why this trial is different, and also probably why this trial actually showed us a benefit. Now, I will briefly talk about urothelial carcinoma, what is the background, then the study design, the efficacy, the safety, and summarize the Javelin Bladder 100. That is the trial that I'll be talking about. A bit about Bavencio also, mechanism of action and how we dose it and any special precautions. Like I said, I am sticking myself in this lecture to Bavencio only. I would give a few words about the other drugs because maintenance as a idea in urothelial is fascinating, and surprisingly, this seems to be the only drug that has actually worked. So that's something interesting. Now, when we talk of urothelial carcinomas, I was actually one of the trial PIs for this study, and when we got it, we knew that, well, it's not that common. It is, however, when you look at overall bladder cancer, it is the most common type of bladder cancer in the world. Worldwide, it is around 10th most common cancer worldwide, with more than 550,000 cancers. Now, when you include all the in situs and all those, then the incidence increases even further. Like most cancers in India, it is not one of the highest cancers. It's one of the tumors there, but if you take the list of the top 5 or 6, urothelial doesn't really come in. Now, the challenge with urothelial carcinomas, as with most diseases, is when you have a regional or a distant metastasis, the 5-year survival is quite dismal. The 5-year survival for all stages was around 77% and 68% in the US and Europe. 5% would have metastatic cancer at diagnosis, 50% would relapse after cystectomy, and many of those who relapse actually have distant cancer. And the 5-year survival of this group is less than 5%. So a rather dismal disease, which is something we are aware of, and really no great difference in the outcomes in the last few years. When you talk of the treatment, chemotherapy has been the standard. Now, in chemotherapy, when you talk of the drugs, it is always platinum containing, more specifically the cisplatin containing. Now, 75 to 80% would achieve some form of a disease control, but overall survival is close to 12 to 14 months. Now, what to do after chemotherapy? It's always an issue with chemotherapy because you have cisplatin eligible patients, then you have cisplatin ineligible patients, and you have those patients who would probably not be eligible for any platinum at all. So you have different groups of patients. So when your patient is either cisplatin or carboplatin eligible, the standard option is to watch and wait after chemotherapy. What has been seen is that after that, around 64% of patients progress within 9 months, and more importantly, a lot of patients, 25 to 50%, will not receive a standard second-line therapy. So a long-term usage of chemo also is not something that we do. Options of maintenance chemotherapy per se, other than a few in-between examples, is not really an option. So it is a space which required a new drug. And that is where Bavencio is something that we have gotten. Now, Bavencio is avelumab. By now, we all know about avelumab. We know about the other PD-1, PD-L1. This is a PD-L1 inhibitor. So it activates and stimulates the anti-tumor responses. By now, specifically, the important thing that we need to also remember of Bavencio is that it is a kind of a specific action against tumor cells and activation of NK cells. So there is also a tumor cell killing through ADCC. When you add the chemotherapy along with this, probably there's a synergistic activity because platinum containing chemo has a direct cytotoxic effect, and that may control your tumor burden, and thereafter the remaining part might be taken care of by the immunotherapy. So that's what actually has been seen, that in those patients who had a smaller burden of disease, they actually did better in responding to the immunotherapy. So again, if you have a smaller tumor volume, you might end up doing better to immunotherapy because the volume you're targeting is smaller. Now, this is not from bladder. These are graphs that are taken from melanoma and non-small cell lung cancer. But again, the principle is kind of similar, though not absolute with bladder cancer. Within bladder cancer, there was an analysis where they looked at second-line durvalumab, and here again, they found the same thing. So if your baseline tumor was around 21 millimeter, they responded better to the immunotherapy. When it is higher, the response is not as good. Again, this is a bit of a statistical jugglery. You're looking at a smaller tumor, therefore a response would translate into a greater fraction and so on. But still, there is something interesting. It does suggest that if you give chemo first, maybe your tumor burden reduces and therefore the concept of an immune checkpoint will work better. Again, this is a nice hypothesis. This is something that can be used to explain what is happening. It is not an absolute, but this is an interesting theory. So whenever you do give a platinum-containing therapy and you get a response, that's where probably a maintenance therapy will help you. Now, added to that, we know that chemotherapy has some immunogenic effects. Gemcitabine is well known with that. So maybe those immunogenic effects may enhance the activity of the immune checkpoint inhibitor. So this was the kind of idea behind using Bavencio as a maintenance therapy. Now, why is that important? Because the study design, if you look at in Javelin bladder, is quite unique. We know that IO works in the second line in urothelial. The way you use it is you give chemotherapy, observe at progression, give immuno versus placebo or immuno versus another chemo. Or you directly go with using your immunotherapy along with your chemotherapy in the first line. So starting from cycle 1, give immunotherapy plus chemotherapy, give it for 4 cycles. Thereafter, continue only the immunotherapy as a maintenance. Now, as you all know, in urothelial cancer, for some reason, none of those trials have succeeded. You have trial with pembrolizumab, you have a trial with Atizo. All of them have failed to achieve any sort of OS benefit. And the addition of the two, that is immuno plus chemotherapy, is not an option for bladder cancer. It's interesting. It's the standard of care for lung. It seems to be working for your G junction. It seems to be working to some extent in breast. But in urothelial, the trials have all come negative. Now, against that, Javelin bladder was a regimen which used Bavencio as a maintenance. So the patients were actually randomized at this point. This is important. You have given platinum-containing induction chemotherapy, patients who had unresectable locally advanced, more than one measurable lesion, 4 to 6 cycles of chemo, which could be either carboplatin or cisplatin. That is the other important point. You could give either of the two. You need not necessarily use only cisplatin. Now, after that, this is where you randomize patients. Now, the patients were tested within 4 to 10 weeks after chemotherapy. So finish the last dose of chemo, wait for around a couple of months, check a scan, see that the patient is in CR, PR, or stable disease, and then randomize to Bavencio versus best supportive care. Remember, best supportive care is the standard arm here. You are not giving any extra drug here. You're just giving the normal antibiotics, nutritional support, pain medication, so on and so forth. So a maintenance immuno starting after chemotherapy. Now, the other point we need to remember is the measurement actually starting from here. So when you look at a trial of immuno plus chemo starting from baseline, you're going to start your measurement at this point because that's where you start your chemotherapy. Here, you're starting your measurement at the point of post-chemotherapy. So extra, you can call it around probably 12 to 14 weeks or 15 weeks after initiating chemotherapy that you are starting your measurement of your OS and PFS. Again, that tells you why the overall survival number itself may not be great, but we need to remember to add 4 months to that. Now, the other point which is interesting is maybe because you are selecting your patients in this way, you are excluding the 15-20% of patients who have progression. You are also excluding that group of patients who are having poor performance status after chemotherapy and immunotherapy. You are excluding that group of patients. We know there's a group 5% maybe, whatever, who will have immunotherapy related side effects early. So all that group is excluded when you are using this measurement. So you can say that is one reason why this trial is successful. At the same time, you can argue that probably this is a better approach because you are able to select your patients who will do better with your immunotherapy. So that's my take on it, that this is the reason why this trial is better and this method of giving immuno is probably better. Now, in this group, the primary endpoint was overall survival. They looked at two groups, the randomized patients and patients with PD-L1 positive, and of course looked at secondary endpoints including PFS. So the stratification factors was best response to chemo, site of metastasis, and so on. Multiple tumor assessments were done at baseline, 8 weeks, and then every 8 weeks till after randomization. So they could continue beyond disease progression if patient was clinically stable and having benefit. So obviously, placebo will not have that. You will have it mostly in the Bevin-Show arm. Now, remember, this was an open label study, so you knew what the patient was getting. This was the treatment arms, more or less well balanced. Interesting for me, yes, there were some Asian patients, around 75. Indian patients were around 5 to 6 in the trial, if I'm not mistaken, or maybe around 8 or 9, less than 10. But there were some Indian patients in this study as well. Mostly everybody was PS 0 and 1 as usual. Now, this is interesting. Stable disease was 27%. Mostly, almost everyone had a PR. A few patients had CR. 54% visceral, non-visceral, which included lymph nodes or unresectable bladder, was 45%. PD-L1 positive for 54, negative for 40%. The first line drugs used 52% cisplatin, 42% carbo. This small group were those who started on cis and then converted to carbo. So roughly equal everywhere. Now, when you look at the results of the efficacy trial, the Bevin-Show plus best supportive care demonstrated superior overall survival. This is 21.4. Remember, we are talking of 21.4 was from the time of starting Bevin-Show versus 14.3. So huge improvement of 7 months, a 31% reduction in the risk of death, hazard ratio 0.69, quite close interval. So tells you that this is something which is consistent. Look at the curves. There is no crossover to begin with. They go on slowly within the first 2 months. They start dividing and then they stay dividing. And the median overall survival does go up to 21.4. We haven't had an update here whether we are really going to see a tail or not. We don't know. That's something which will be interesting to observe later on. When you look at the PD-L1 positive numbers, there is a slightly better hazard ratio, 0.56, but numerically in this group, the median OS was not reached. Here it was 17.1. So again, should this mean that we restrict our drug to only PD-L1 positive? Not really. It does mean you do get a benefit in both the groups. What about the landmark things, landmark analysis at 18 months? Again, in randomized patients as well as in the PD-L1 positive, you do continue to see your benefit. Now, across subgroups, when you looked at the age, sex, PS, and everywhere, there was a benefit. When you looked at, more interestingly, this part, patients who got cisplatin or carboplatin, both benefit. This group I don't consider, it's only 7 patients. Then best response, whether patients had a CR or a PR, they benefited. Those who had stable disease, well, just crossing unity, but still seem to do good. Looking at visceral mets versus non-visceral, again, both seem to work. PD-L1 negative. Now, the numbers are smaller here, and here your hazard ratio is 0.86. So you are getting a positive result in the PD-L1 positive. In the PD-L1 negative, well, not a very good p-value here. Not the hazard ratio is 0.86 and non-significant. So you could argue that the maximum benefit is derived from the PD-L1 positive person. Looking at PFS. Now, interestingly, look at this curve. They both almost merge till almost 2 months, and that's where the PFS advantage you're starting to get. So that also tells me that the patients who get this PFS advantage probably are the ones who are going on to a slightly longer OS as well. So PFS at 12 months is 27 versus 13. At 15 months, it's still 26.9. So from 12 to 15, not much loss here. So this starts getting a bit more stable. Overall, the hazard ratio is good. So again, a PFS of 30% at 12 months. Median PFS is around 3.5 months versus 2 months in the best supportive care. So this is what it is. So your PFS as usual is not great when you give immuno, but then those who do well continue to do well for a longer period. Now, when you look at the other part, which is the number of patients who got a second-line checkpoint inhibitor, best supportive care around 44%. In those patients who discontinued due to progression, again they got a PD-L1 in around 53%. So half the patients did get immunotherapy. This is again a glass half full situation. You can say that if maybe 80% of patients had got this, we would not have seen this OS curve. But then in real life, not everybody gets it, and as such, the number of patients who go for a second line are less. Coming to safety and tolerability, as usual, the drug is pretty well tolerated. We know that, not too many grade 3 side effects. The quality of life is maintained. In 9% of patients, you did have to give high dose corticosteroids, but the rate is only 7%, which is not bad. No fatal results. Now, the other part is how many patients remained on treatment for at least 6 months, around 47 in the Bevinchon and 28% in the other. So if you have to summarize this study, it is a very good option with proven overall survival benefit. It's a first-line maintenance, which meant it gives you 7 months improvement in OS, which is better with the PD-L1 positive. PD-L1 negative subset analysis doesn't show you that, but then overall there is a benefit. So safety and efficacy is good, tolerability reasonably good. It has been recommended by ESMO now for those patients who have not got this. And again, for me, more than just this trial alone, the fact that immuno plus chemo did not give you any OS is significant. So for me, the first line at least is this is where I'll be using my immuno. Patients will be given chemo first. Those who do well, they are automatically being selected, and that's where I will start my immuno, rather than pushing immuno together, increasing the cost and the toxicity. Dosage wise, well, this is pretty much standard. We give a flat dosing, 800 mg once in 2 weeks. Those modifications, again, charts are there, how by and large grade 3 and grade 4 you will discontinue, grade 2 you can withhold and restart. A whole bunch of all the treatment related adverse events. You have a patient, you can look up these things. A special warning, nothing really specific, more or less everything which is similar to the other immune related side effects. And again, a whole bunch of effects which we are all aware of by now. This is not something that is new to us. All the immune related toxicities, including the endocrinopathies. So that's my study. And again, to summarize, it's a new paradigm in treatment and probably something that in urothelial gives us a glimmer of hope. Thank you.
Thank you, Dr. Vamshi, for that excellent talk. May I ask you how many of your patients are currently are on prevention maintenance therapy?
I have to be very honest and put up my hand and say right now none, because the few patients we did get who are post drug, they cannot afford the drug. So right now nobody. But in the trial we had one patient who was on the best supportive care, and we didn't see good response. And many of these patients who are post chemo generally don't do well.
Okay, you are in the same boat as I am. Even though I'm also interested in using this drug, but because of the cost constraints, I have not been able to use it. The next question I would like to ask: for how many months delay is permissible in starting this maintenance? Suppose someone
Yeah, so the trial allowed 4 to 10 weeks. In clinical practice, does this mean that if somebody comes on the 11th week, I will refuse it? Typically, no. Probably I will be okay up to 12 months. Up to 3 months probably is okay.
So a unique situation, if I give you patient comes 3 months down the line, that is 12 weeks, and you get a with a PET CT report which shows there is no evidence of disease. Would you be interested in starting treatment with this drug or not?
Yes, I would. If it is a urothelial and it has responded so well to chemo, I would want to maintain the response. Because I know that if they progress, around 20-30% will not be in a position to take any second line. So I would want to start my immuno now rather than reserve it for later.
Okay. Thank you, Vamshi. Thank you. That was very exhaustive. And let me move on to my talk. I will be switching to another meeting.
Yeah, can you, someone can tell me whether I'm visible and whether I'm audible or not, and if someone can share with my slides, or let me do it from my side. Uh, Organizers, can you share my slides?
Yeah, you are perfectly audible and visible, sir. I am from support team. So may I share your slides, sir, from my side?
Yeah, please do that.
Yeah, sure, sure.
Let me try from my side if I am able to use. No, I'm not able to do it from my system. Okay. So this is the last session of the GU oncology. We started with the prostate cancer, moved on to the bladder cancer, and now it's my turn to talk about the kidney cancer. I will take about 10-15 minutes to wrap up this talk and then hand over the session to the GI coordinator. So how I treat MRCC, I'm Dr. Sandeep Batra, a medical oncologist based at NAC Saket and Gurgaon. Next slide, please. Can we move on to the, yeah. So first line therapy, next slide, please. So as soon as a patient of first line presents to me, the first thing in a stage 4 MRCC patient, as soon as the patient walks into my clinic, after a clinical assessment, I need to decide what is the IMDC score of this patient. So I am more comfortable using IMDC score than the MSKCC score because it is much more simplistic. So all of us know what are the risk factors, but just to enumerate, there are these 6 risk factors enumerated. So patients with a time from initial diagnosis less than 1 year, 1 versus 0, if present, then 1, if not, then 0. KPS score less than 80%, if present 1, then 0, and so on and so forth. Between the hemoglobin, high calcium, high platelet, and high neutrophil count. If any of the features is present, it is given a score of 1. If they are absent, it is given a score of 0. So we divide the patients into 3 categories, favorable, intermediate, and poor risk groups. And if there is no prognostic factor, it is a favorable risk group. 1 to 2 prognostic factors present, it's intermediate group, and 3 to 6 prognostic factor, it's a poor risk group. And most of the patients that present to us in India and most of the world is 75 to 80% are in the poor on the intermediate risk group. Next, please. Why this differentiation is important is because after a study of more than 700 patients, it was found out that presence of these factors, irrespective of the treatment, decided what is the fate of the patient. And as you can see from this graph, this curve, that if the patient was in the favorable risk group, there were 75% survivors beyond 4 years. And if it was an intermediate risk, there were 50% survivors beyond 4 years and more. And if it was a poor risk, clearly less than 7% survive beyond 3 years or more. So that's the simplicity of this scoring system. And it's also, besides prognosticating, helps us decide which particular treatment is most suitable for this patient. Next slide, please. Now, the next question that comes to my mind is whether this patient is eligible for cytoreductive nephrectomy or not. With the current evidence, I think it will be a mere coin throw to find out whether it is yes or no, because after the Carmina trial, it has been very well proven that cytoreductive nephrectomy, unless until some exceptional circumstances, does not have any overall survival benefit in the metastatic RCC patients. Next slide, please. So Carmina trial, it was a multi-center randomized open-label non-inferiority phase 3 trial with the primary endpoint of overall survival. Secondary endpoints were progression-free survival, response rates, clinical benefit, and safety. There were 450 patients included, and they were mostly IMDC intermediate or poor risk. Sunitinib alone versus cytoreductive nephrectomy followed by sunitinib was the schema. And the median overall survival was 18.4 months for sunitinib versus 13.9 months for the cytoreductive nephrectomy followed by the sunitinib. So if you see numerically, there was almost 5 months different, and the sunitinib was winner as compared to the surgery followed by sunitinib. Another trial in which there was some deferment of surgery after doing it after 3 cycles of sunitinib and then continuing with the sunitinib. Overall survival improved in the intention to treat population, but not as per the per protocol population. So that's why I said exceptional circumstances in which there is a minimal extrarenal asymptomatic disease, or if there is an exceptional response to systemic therapy, are the conditions which will provoke me to think about the surgery. And another is the clinical problem of a bleeding renal cell tumor, which has not responded to either palliative hemostatic radiotherapy or the renal vessel embolization. As a desperate measure, which you can offer these patients surgery, but not as a routine. Next slide, please. So next is the schema for the Kabina, which we have discussed. Next slide. Rahul, please, next slide, please. Yeah. So this is the schema, 450 patients, nephrectomy followed by sunitinib and sunitinib alone, follow-up for minimum of 2 years, and BFCs. Hands down, overall survival did not improve with the cytoreductive nephrectomy, gave the cost, the toxicities of the surgery, the financial one, as well as the infective one. So per se, it is hands down for any cytoreductive nephrectomy in a stage 4 MRCC patient upfront. Next slide, please. So overall survival curve, you see, they are intermingled with each other, suggesting that there is no benefit of using two modality and only sunitinib suffices for the majority of the patients. Next slide. So another strategy is active surveillance. Though active surveillance is one of the advisable options in the guidelines, but I do not have the courage for advising active surveillance for any of my metastatic RCC patients. Theoretically, though, favorable group patients with 0 or 1 prognostic factor with a metastasis in less than equal to 2 organs, it was shown that the survival difference was 22.2 months versus 8.4 months with the unfavorable group having a survival of 8.4 months. So active surveillance without any treatment can be offered for favorable group patients with the risk score of 0 to 1 with the metastasis, minimal extra renal disease confined to less than 2 organs. But as on today, I have not met any of the medical oncologists till date who has offered active surveillance, and even I have not offered to any of my patients. But theoretically, yes, it is one of the options. Next slide, please. Now, these guidelines we repeatedly come across, and based on the IMDC criteria, we have already divided the patients into the favorable and the poor intermediate risk that we have already done. Now, if you, the best combination as on today is either IO-IO combination in the poor or intermediate risk group, or it is TKI combined with the IO, and take an IO, take a TKI, combine it in various permutation combinations, and either the trials are already completing, showing their benefit, or they are underway to show their benefit. So if we go by what is as per the recommendation is axitinib pembrolizumab combination, cabozantinib nivolumab combination, lenvatinib pembrolizumab combination, they are all approved for a favorable risk group, and pazopanib and sunitinib as a single drug. When we come to the poor or intermediate risk group, axitinib plus pembrolizumab, cabozantinib plus nivolumab, ipilimumab plus nivolumab, lenvatinib plus pembrolizumab, they are all category 1 recommendations. So if you can see, EP plus Nivo is category 1 in the poor and intermediate risk only, and it becomes a category 2 recommendation in the favorable group. This is based on the data from the trial, phase 3 trial that was done for the intermediate and the poor risk group, and did not include in much of the good risk patients. Next slide, please. Now, if I talk about myself, as on today, the favored combination from my side, you have to go to the next slide. Organizer, please, next slide. So I have shifted my practice to nivolumab plus cabozantinib. I have used pembrolizumab plus axitinib. Previous slide, please. Previous slide. I've used pembrolizumab plus axitinib, pembrolizumab plus lenvatinib, nivolumab plus cabozantinib as a combinations in the favorable group, and also EP plus Nivo combination in the poor risk patients. So from the personal experience, because this talk is how I treat, I would say that even though EP and Nivo is a category 1 recommendation for the poor and intermediate risk, 2 or 3 old patients which I was able to give this drug combination despite the challenges, despite the financial toxicities, there was not a very good response. So probably it was the disease biology with the poor and intermediate risk group rather than the combination that did not work. But there is one remarkable finding that one out of those 3 patients who took 4 doses of Nivo and AP, followed by a disease getting progressed after 3 months of evaluation, that is 4 doses. We tried giving single agent cabozantinib, but it was not tolerated in the form of toxicities, cardiac toxicities, and it took only about for 3 or 4 weeks. It is 1 year, he is off any treatment, and he has got a stable disease with no clinical symptoms. So that I would attribute to a immuno combination that has worked the trick, and the patient is still asymptomatic without disease progression. Now coming to all the 4 trials, Checkmate 214, IPI and Nivo versus sunitinib. So beauty of all these trials is, as compared to the other diseases and trials in which there is a best supportive care as the control arm, we had sunitinib as the control arm. So at least we have an active drug, or rather a very active drug as a comparator arm. And if you show a response with a very, very active comparator arm, that means your drug has some potential, and it is better if it is proven in the trial. So Checkmate 214 was predominantly for the intermediate and the poor risk. If you see the overall survival difference, it was 55.7 versus 38.4 months. And if you see the overall response rate, it was 39 versus 32%. And if you see, majority of the patients were 61% in the intermediate and 17 in the poor risk, and only favorable were only 23. So based on this trial, this drug was given a category A recommendation in the NCCN for the poor and the intermediate risk. Now coming to what I prefer and why I prefer is based on the Checkmate 9 ER trial, which is cabozantinib plus nivolumab. No doubt, Pembro and Len is also comparable, but I am still not able to handle the toxicities by the combination. So coming to the cabo versus, plus the nivolumab, if you see the overall survival comparable, 37.7 versus 34.3 months with a hazard ratio of 0.7. And if you see the median PFS, 16.6 versus 8.3 months, overall response rate 56 versus 28, almost doubled up. And CR rate were highest after the Pembro-Lenvatinib combination, 12 versus 5. Primary progression was in the minimum number of patients as compared to the Ipi-Nivo, which was 18, Axi-Pembro, which was 11, it was only 6, and Lenvatinib-Pembro fared better with the 5 primary progression while on the treatment. So, and there was less number of patients which shifted to a second line, suggesting that Cabo and Nivo were showing a response even after discontinuation. Next slide, please. So this is the Nivo-Ipi combination, Checkmate 214 in the poor and the intermediate risk. And since I have used this drug, so I will vouch for this drug combination. If there are no financial challenges, this is the combination to be used in this patient, even if it is not a very high percentage of response, not a very high percentage of complete response. Still, there is a lingering effect of the immunotherapy leading to a longer disease-free survival. Next, please. Next. And if you see, even if there were less number of the favorable risk group patients, the curves did not separate out as compared to the poor and the intermediate risk. So it was preferred. 4-year progression-free survival probability was 31 versus 12.3%. Median overall survival was not reached versus 38.4 months. And for the intermediate and poor risk, it was almost 4-year survival for the active treatment hour versus 26 months for the comparative. Next slide, please. Pembro plus axitinib, since the discussion is about how I treat, so I have treated quite a few patients when the other options were available, but after the launch of the cabozantinib and by titrating the dose, I am able to manage Nivo plus cabozantinib, and also you have the privilege to see the patient every 2 weeks for an assessment. Otherwise, with the Pembro plus axitinib, it's a 3 weeks follow-up. So things like hepatotoxicity, etc., they are picked up very early with the Nivo plus cabozantinib combination, and plus the ease of doing it tilts me more in favor, though data equally favors everything. Next slide, please. So again, intermediate and poor risk, the curve separated out well in the Pembro plus axitinib arm. Next slide. And again, in the good risk group, they separated, but not to the extent it was seen in the other group. Next slide, please. So again, we have already dwelled upon this Nivo plus cabozantinib combination, checkmate 9ER. So following it in most of my patients right now who are eligible for this combination. Next, please. Now, if you see poor risk, intermediate risk, the curves are still separated. 80 versus 74% median OS difference in the intermediate risk, and 78 versus 45% different in the poor risk. Next slide. Favorable risk in the Nivo plus cabozantinib arm, the curves later on separated, but earlier they were intermingling. Next slide. Next. Now, having read the lenvatinib plus pembrolizumab, I think there is some more beauty in len plus pembro combination as compared to Nivo cabo. That's a cross trial comparison, and I may be wrong in doing that. But if I go by the statistics, this looks a more promising combination as compared to the other combinations that we recently discussed. If you see, lenvatinib plus pembrolizumab gave the hazard ratio of 0.66. And since this trial also had an arm for combining lenvatinib with everolimus, the hazard ratio for which was 1.15, so it was not favored to be used in the upfront metastatic setting. Next slide. So across the board, except for the favorable group, every group based on the demographics responded well and had a significant difference in the outcome as compared to the control arm. Next slide. So high response rate, CR rate was 16.1, which were highest as compared to all other trials. Median progression-free survival was 23.9 versus 9.2 months. Again, maximum out of all other trials. And there was superior median overall survival with a hazard ratio of 0.66. So above mentioned distinguish this trial from other ICI TKI trials. So I think real world data, if it matches with what is seen in the trial, it is going to become a darling as a combination for most of the medical oncologists. Next slide. So again, not a very good way of doing the things, but cross-trial comparison. If you see the overall response rate, Nivo plus ET 39%, Pembro plus Exitinib 60%, Nivo Cabo 56%, and then you have Pembro plus lenvatinib 71%. And rate of progression was maximum with the Nivo plus EP and minimum with the Pembro plus lenvatinib. Next slide. So having done the first line therapy, so most of my patients, if they are eligible, they have the finances, they go on to Nivo plus cabozantinib, and probably I may move on to Pembro plus lenvatinib in due course of time. If there is affordability issues, financial issues, or contraindications to immunotherapy drugs, then single agent lenvatinib versus cabozantinib versus pazopanib are the options that I'm going to choose. What next after the first line is over? So suppose the patient has received Nivo plus EP in the first line, then I will choose a single agent cabozantinib in the second line. And once I've exhausted the cabozantinib option also, then I will go for a lenvatinib plus everolimus option. Only in its absence, I will choose exitinib. And just to complete the sake, in the third or the fourth line, we have approval of tivozinab, but right now it is not available in India. So I will need to. So the one thing is very clear: having used the immuno-oncology drugs in the first line, there will be very rare circumstances in which I will be using the immuno-oncology drugs again. So I have to resort myself to TKIs mostly, sometimes TKI plus immuno-oncology combination based on the duration for which the response was there. Next slide. If I use cabozantinib as a single drug in the first line, then I will go for Nivo plus EP alone, or nivolumab alone, or exitinib plus pembrolizumab. This is all permutation combinations that I keep on doing. It's not based on any specific set rules. It's based on the use of the data and the personal interpretation of the data. Having exhausted the immuno-onco combination, lenvatinib plus everolimus versus exitinib, and failure of that, any drug which has not been used in the past. Next. Having used XZ plus Pembro or XZ plus Avelumab, again Cabo with Nivo, Cabo or Nivo or EP, so on and so forth. I think you are free to choose based on the drugs that has been used in the first line. And if the immuno-oncology drugs have been used very long in the past, there is always a case of using these drugs. Next slide, please. Again, if you have used cabo-nivo combination like you use in most of the patients, then limitinib plus everolimus in a rapidly progressive disease, and if patient has had a slowly progressive disease, then I will definitely give it a try of immuno-oncology combination dual drugs, nivo plus ipi, followed by the single agent TKIs. Next. Again, the same philosophy, having used one particular combination, it's time for the next TKI. And if there is a prolonged response in the past with the immuno-onco TKI combination, try to use in the third line as well. Next. Okay, so with this, I think I will have used all my slides. I will be happy to take my questions from any of the participants or faculty if they have any question. If there are no questions, then I think I will close the session for the genitourinary oncology and would start with the gastrointestinal oncology. And we have with us Dr. Sumit Goyal. He's a senior consultant, associate director, medical oncology at Rajiv Gandhi Cancer Institute. And he will be speaking on, just a minute, I've forgotten the topic. Just give me a minute. Can you please share the, yeah. So immunotherapy in esophageal cancers, adjuvant and recurrent or metastatic setting updates. And Dr. Sumit, are you there? Dr. Sumit?
Dr. Sumit.
Hello, I'm there, sir.
Yeah, now unmuted.
Yeah, Dr. Sumit. So I request you to please start your talk, and I will request you to take care of the hall. Due to some exigency, I will need to leave. I will try to join back and ask some of the questions to the faculty. Thanks for your patient listening and hearing. Thank you.
So same questions. My slides, are they visible and am I audible?
Yes, they are visible and you are audible, sir.
Okay. Thank you, Dr. Sandeep, for your wonderful presentation. It was really very crisp and nice. So moving on, so the next session is GI oncology. So I will be presenting data that is available to us on immunotherapy in esophageal cancer. The next talk is by Dr. Ankur, and he will be speaking on gastric cancer tumors basically. So I try to restrict it to the esophagus basically. So we know there is a lot of mortality in esophageal cancer in both the sexes. It is a sixth leading cause of cancer of death, cancer death. And if we look at Asian region, definitely the incidence and the incidence of mortality is much higher as compared to the rest of the world. And in our part of the world, mostly the esophageal cancers are the squamous cell cancers, comprising approximately 90% of the cancers, which are little different as compared to the Western world. So with high mortality and limited armamentarium available to us, definitely there is an unmet need to involve and to get more drugs in the landscape. So with availability of checkpoint inhibitors, definitely they are making their way into this scene of esophageal cancers. So basically, if we look at the standards for operable esophageal cancers, so basically we have nothing once we do chemoradiation and surgery. After that, we are left with just observation and close follow-ups. And in the adjuvant setting, we have data coming from Checkmate 577 to use in the adjuvant setting. So this was the study, basically Checkmate 577. So adjuvant nivolumab in resected esophageal or gastroesophageal junction tumors after neoadjuvant chemotherapy. So again, it is not established, there is no established adjuvant therapy in this setting. So Checkmate 577 trial evaluated safety and efficacy of adjuvant nivolumab and in patients who had undergone neoadjuvant chemoradiotherapy and who had residual disease post-surgery. And so this was the schema of the study. It was adjuvant nivolumab in esophageal cancers or gastroesophageal junction tumors. The key eligibility criteria were again stage 2 or 3 cancer patients who have completed neoadjuvant chemoradiation and surgery and who had residual pathological disease following the complete resection. The primary endpoint was DFS and key secondary endpoint was OS. So 2 arms, Nivo versus placebo. It was a global randomized study. Majority of patients were non-Asian population and dominated by esophageal adenocarcinoma histology, which is little different from what we get to see here. So though the studies, both the arms were well balanced, squamous cell cancers were 71% as compared to 59% in both the groups. And if we look at the results of this study clearly showed in the high-risk resected esophageal cancers, if we look closely here, the disease-free survival was just doubled. It doubled from 11 months to 22.4 months in the Nivo maintenance group. And if we look at the histological subgroup, so we can clearly see the dotted lines, they are squamous cell, and the bold lines, they are the adenocarcinoma. The margin of benefit was there in both the subsets of patients, both adeno and squamous. However, the margin of benefit was much more in the squamous cell group. So if we look at the DFS survival in the adenocarcinoma group, it was 11 versus 19.4 months, whereas in the squamous cell, it was much better. It was 11 months as compared to 29.7 months. So again, do we need a biomarker selection for adjuvant nivolumab? So the authors concluded that there was no difference according to the tumor PDL1 or TPS score, and the post-hoc analysis suggested benefit only for PDL CPS score more than 5% of patients. So the conclusions of this study was, though there was 31% reduction in the risk of recurrence with double median DFS, it led to clinically meaningful reduction in distant and local regional recurrences, and it also prolonged PFS too. So the conclusions was that it is the standard of care after trimodality therapy, chemoradiotherapy and surgery for patients who have residual disease in the resection specimen. Both adeno and squamous cell cancers patients they benefit. No biomarker selection is recommended for adjuvant nivolumab as of today. So when we come to the advanced esophageal squamous cell cancers, we have checkpoint inhibitors in first line, second line, and beyond that. So we have two studies, Keynote 590 and Checkmate 648, which was used in patients who had either PDL1 CPS score more than or equal to 10 or TPS score of more than equal to 1. And in second line, we had attraction-free nivolumab in the second line study in the squamous cell subset. So these were the two practice-changing trials in first-line esophageal cancer. They were used in treatment-naive patients who had advanced esophageal cancer. They were either given chemotherapy alone, along with PDL or PD1 inhibitors. So the primary endpoint, so again, the majority of the patients, they were from Asia. In Checkmate 648, 70% of the patients were from Asia as compared to 50% in the global studies. So in the Checkmate 648, the comparative arm of chemo was cisplatin plus fluoro 5-FU, and no chemo was used in the immunocheckpoint inhibitor arms. In Keynote 590, it was again the same of cisplatin plus 5-fluorouracil. So in Checkmate 648 arm, it was almost all the patients with squamous cell carcinoma, and in Keynote 590, it was 74% of the patients had squamous cell cancer. So looking closely, Checkmate 648, so which was first line advanced squamous cell esophageal cancer trial. Again, the eligibility criteria are unresectable disease, advanced, recurrent, or metastatic disease, who had not received any prior systemic treatment, and they had measurable disease. They were randomized 1:1:1 into either Nivo plus chemo arm or Nivo plus EP arm or chemo alone arm. So again, the studies were well balanced in all the groups. So if we look at the results, so in the chemo versus chemo plus Nivo arm, if we look at the median OS in all esophageal squamous cell carcinomas put together, the median OS was 10.2 months as compared to 10.7 months with the chemo alone arm, and hazard ratio of 0.74. Median PFS 5.8 versus 5.6 months. But if we look at the patients who had TPS score of more than 1, the results were better. 15.4 months versus 9.1 months. And clearly the same thing represented graphically. So the benefit was there, but the benefit was more pronounced when the patients had PDL1 TPS score of more than 1%. So again, the post-hoc analysis was done. PDL1 TPS versus combined CPS score was done. So they, in this study, they found that there was no benefit if the PDL1 CPS score, TPS score was less than 1, and PDL1 CPS identifies more patients who benefits than TPS, and there is no benefit again in patients who have CPS score of less than 1. So again, checkmate as compared, that was the previous results were with chemo plus Nivo, and this is with chemo versus Nivo plus EP. All chemo arm versus all immuno arm. So again, median OS was better, 12.7 versus 10.7 months. And when we look at the results with patients who had TPS more than 1%, it was 13.7 versus 9.1 months. So if we look here, so it was better in patients who had received chemo plus Nivo as compared to immuno alone arm. So the take-home messages from this study is the Nivo plus platinum 5-FU combination is new standard of care in treatment-naive advanced esophageal squamous cell cancer. The best results are seen with patients who have PDL TPS score of more than 1%. This is category 1A recommendation. And a pre-planned exploratory analysis demonstrates PDL1 CPS score of more than 1% also shows strong benefit. And there is no benefit in patients who have PDL1 TPS CPS negative. So, and EP plus Nivo can be considered in treatment-naive advanced esophageal squamous cell cancer patients in where TPS score is more than 1%. So again, the second study, Keynote 590, again, this study had approximately 74% of patients who had squamous cell carcinoma. Same, the adenocarcinoma subgroup patients were also there. The study was randomization between the chemo and the chemo plus pembro arm, and pembro plus chemo, which was 5-FU, given for 35 cycles, and cisplatin was 6 cycles. And if we look at the results, again here, it had only 74% of the patients had squamous cell, others were adenocarcinoma were also there. And 50% of patients from Asian region, and PDL1 score more than 10% was there in 50% of the patients. So looking at the results in the squamous esophageal group, so if we look at the all esophageal squamous cell carcinoma group, the median OS was 12.6 months as compared to 9.8 months in the placebo. And if the score was, CPS score was more than 10, the benefit was definitely more and higher, 13.9 months versus 8.8 months. So definitely benefit was there in all the subgroup of patients irrespective of PDL1 status. But if the score was more than 10, the benefit was much more pronounced. So again, if we look at the patient subset who had adenocarcinoma, again the PDL1 CPS score of more than 10, there was clearly separation of the curve showing the benefit. And but if the score was less than 10 in adenocarcinoma patients, there was no much benefit. And the magnitude of benefit was less in adenocarcinoma as compared to squamous cell carcinoma that we have seen in the previous studies also. So this is the same thing. So the investigators' conclusions from this study was overall responses were good, and even after 12 months of additional follow-up, the median duration of response was 8.3 months, and quality and safety profiles were similar between the treatment arms. So the take-home from this was pembro plus platinum 5-FU combination is new standard of care in treatment-naive esophageal cancers, both adeno and squamous. However, the benefit in adenocarcinoma group was less if they had CPS score of less than 10. So the other trials in advanced squamous cell cancer, they were consistent with benefit of anti-PDL1 therapy in Asian patients. We have 3 trials there, ESCOT-1, Orient 15, and Jupiter. All had shown survival advantage with p-value significant. And the same thing, if the PDL1 scores are more than 1%, the results were more beneficial. Results like the OS was between the range of 15.3 versus 217 in the immuno group. So different class of drugs were used though, but it has shown a class effect in both esophageal squamous cell cancers, and we do not need 5-FU backbone for efficacy. This study shows that. An inconsistent effect of PDL1 expression was noted in these studies. So another study, checkmate 649, it was the interim additional analysis was done here. It contained only gastric cancer patient, cancer patients who had, this was the schema, Xelox or Qualcox as combined with Nivo plus the same chemotherapy arm. So here, all the patients had basically adenocarcinoma arms. So if we look at the results were similar. They had shown benefit. In the OS was better in the Nivo plus chemotherapy arm, 13.8 months versus 11.6. And if we look at the PFS, again, the PFS benefit was also there. So there was significant lasting increase in OS and PFS when Nivo was combined to the chemotherapy as compared to chemotherapy alone. So if we look at the PFS2, again, the investigators showed when the immuno was used along with the chemotherapy, these patients, they had better PFS2 also as compared to the chemotherapy alone group. So there was 25% risk reduction in death or disease progression on subsequent therapy with Nivo plus CT as compared to CT alone group. So again, coming to the duration of response, yes, if the CPS score is more than 5, the benefit is much more as compared to those patients who had CPS score of less than 5. So the definitely more positivity meant more duration of response. And again, the depth of response, the patients who had more positivity, clearly they had more depth of response also. So CPS score more than 5, patients have both longer durations and depth of responses. So this study concluded improvement in PFS2 was observed, OS improved across key subgroups, and the incremental value was higher at the higher PDL1 CPS cutoffs, and there was improved overall response rates across all CPS subgroups, and more deeper and durable responses were there. So coming to the second line therapies, we had affection 3. Affection 3 study was used basically in squamous cell carcinomas who are refractory or intolerant to first line 5-FU platinum based chemotherapy. And Nivo was compared with Dosi or paclitaxel arm. We can see the median OS was better in Nivo group as compared to the chemo alone group. And the 12-month survival rate was 47% as compared to 34% in the chemo group. And 18 months, that 18-month survival rate was much better, 31% and 21%. So clearly, if the patients who were responding, they were still responding at the later point in time also, and the side effects were comparable. So better overall survival, lower toxicity with nivolumab. And again, the investigators concluded no biomarker selection was required, but most patients were PDL1. But we know that if the patient is PDL1 positive, these drugs will be used upfront in the first line setting. So the key take-home messages from this study was it is a standard of care in esophageal squamous cell cancer, which has previously been used by abuse and cisplatin, and no biomarker selection is required. And other studies of anti-PDL1 second line esophageal squamous cell cancer is Keynote 181, SPOT, and Regional 2. Again, they had shown benefit. Again, anti-PD1 has the class effect in second line esophageal squamous cell cancer. Benefit is seen in global and Asian studies, and best efficacy is there in PDL1 expressing patients. So last study, which was Keynote 811, it was combination of Pembro plus trastuzumab and chemotherapy who were HER2 positive in metastatic gastric or gastroesophageal junction cancers. So phase 2 results ensured the Pembro can be combined with trastuzumab chemotherapy, and it had manageable safety and anti-tumor efficacy. So the interim results are presented here. This was the study schema. Pembro plus trastuzumab with combination of either 5-FU capox or cisplatin, which was continued up to 35 cycles post progression. So if we look at the overall response rates, it was responses were much higher as compared to the placebo group, and the disease control rates were even much higher, and the duration of responses again were much better when the Pembro and trastuzumab was compared to placebo plus trastuzumab, and the depth of response again was much higher in this subgroup of patients. The same thing, the Pembro, the more than 80% decrease was there in double the number of patients in the placebo group. So again, this study concluded that there was more than 22.7% improvement in overall response rates when Pembro was added to trastuzumab. So the take-home message is the guideline changes in esophageal cancer, basically first-line advanced esophageal squamous cell cancer. Nivo is recommended for patients with tumors PDL1 TPS more than 1. Nivo plus EP can be considered for tumors with PDL1 score TPS more than 1, but that is category 1B. And first-line advanced esophageal squamous cell cancer, Pembro is recommended for patients with tumors who have TPS score of less than 10. Second-line squamous esophageal cancer, Nivo is recommended for patients previously treated with chemotherapy. And in operable GE junction tumors following trimodality therapy without the pathological complete response, adjuvant Nivo is recommended as shown by 577. With this, thank you. I'll stop here. I'll stop sharing my screen, Delhi. So Dr. Minu Walia will be speaking on systemic treatment in advanced stage hepatocellular cancer. Dr. Minu Walia, ma'am, over to you. You are not audible.
Thanks, Dr. Sachin. Thanks, organizers, for this opportunity. And let me share my slides. Just a sec. Just 2 minutes. Share slides. Okay. I hope the slides are visible and I'm audible too.
Yes, ma'am, you are.
Yeah. So let me come straight to the topic. All I'm going to talk about is systemic therapy in the management of hepatocellular carcinoma. Hepatocellular carcinoma, as we know, is the most frequent primary liver cancer, causing approximately 7 lakh odd deaths every year. And it is a result, invariably in all the cases, it is a result of disease on a chronic liver which is already diseased. Going further,
Ma'am, click anywhere on the slide. Yeah, done, ma'am.
yeah. So going further, we know that both the incidence as well as mortality from hepatocellular carcinoma seems to be increasing year on year. Even in my own clinical practice, I would say that we are seeing a lot more hepatocellular carcinoma in today's date that we used to see earlier. Probably a lot to do with the metabolic liver disease. Why is hepatocellular carcinoma so lethal? And in short and simple words, it is because it is not just one cancer that we are dealing with. It is not one disease that we are dealing with. We are dealing with actually two diseases in the same individual. So it is a carcinoma that happens in a person who already has a compromised liver or a compromised organ, a very important organ. Coming to the most important things in the management of hepatocellular carcinoma or the ABC of hepatocellular carcinoma, I say is the anatomical extent of the tumor or the stage of the disease, the biological aggressiveness or the grade of the disease, and cirrhosis, the underlying cirrhosis, the severity, and the functional status of the liver. The staging investigations typically include the multi-phase CT, MRIs, and thoracic scan and a bone scan. And treatment options, we all know, will depend on the stage of the disease. And there are multiple treatment options for these patients, whether we talk about surgical techniques, the surgical options, or local ablative therapies, or our radiation colleagues, they chip in, or again, the most important thing, as we always say, is the systemic therapy. Barcelona Clinic liver cancer staging. The majority of the patients, what we see in our clinical practice, they belong to the stage B, C, and D. That is what majority of them belong to. Yes, once in a while we do get early stage incidental diagnosis also. So systemic therapy, what we talk of, is mainly limited to the intermediate stage B and C. This is the group that we will be addressing, where we talk about systemic therapy. Advanced, the stage D, probably the performance status is so poor that there is hardly any options left for the patient. Coming to the therapeutic options for this advanced hepatocellular carcinoma. So going back, way back in history, sorafenib was first approved by FDA in the year 2007. So almost for a decade, till 2017, there was no other therapy that was approved. And we only, all of us, all medical oncologists, we only had sorafenib, and sorafenib. Yes, there were multiple trials during this period also, but majority of these trials were negative. Many TKIs, many mTOR inhibitors, including sunitinib, erlotinib, everolimus, these all were tried, but the trials were negative trials. So it was later, after 2017 or 18 onwards, that we again had in the first line few more options. And looking at the latest guidelines, NCCN 2022, the systemic therapy, the first line options, we can see actually three. Either it is sorafenib, lenvatinib, atizo plus bev combination, and in some cases with the caveat that it comes as nivolumab. And this is again the first line options, and nivolumab with a caveat, and also yes, chemo, but most of us do not resort to chemo. That is also category 2B, and also in a very minority of cases. So before we talk about systemic therapy for advanced hepatocellular carcinoma, what are the major considerations that we need to do? So what is important is the key concepts in the management of managing these cases is, one is a child book scoring for all these patients that needs to be done. And we know that majority of our patients in the clinical practice generally comes in child book B. Yes, once in a while we do find patients with child book A also, where the liver seems to be quite compensated, or the least severity is there with 0.5 to 6. Child book B, which is majority, is moderately severe, and yes, sometimes we also have a highly compromised liver with high bilirubin levels, low albumin levels, deranged INR, severe ascites, and this is child book C. So apart from the child book grading or the score of the patient, other important parameters that needs to be taken into assessment before deciding is the level of portal hypertension, the level of extent of esophageal varices, whether the patient has been having variceal bleed, because we know that with some of the targeted therapies that we use for hepatocellular carcinoma, these variceal bleed can be exacerbated. And in our clinical practice, if a patient has not had recent upper GI endoscopy, we generally recommend an upper GI endoscopy to be done prior to therapy initiation. Another very important aspect of clinical management is whether the patient is hypersensitive or not. Because yes, we know that some of our systemic therapies may exacerbate hypertension or pre-existing hypertension if it is not controlled well. And if at all the patient have had prior treatments, for whatever reasons, the tolerability of those prior treatments, even including if TACE and all these things have been done, we would want to have an assessment for that. So coming back to, after having had all these assessments, coming back to what are now our first line therapeutic options for this group of advanced hepatocellular carcinoma. If again, going by the guidelines, possibly a patient, a very fit individual, child book A category, atizo and bevacizumab has recently become one of the category 1 recommendations, immuno plus bev. So this recommendation came after this phase 3 trial, I am Brave 150, where atizo plus bev combination was compared with sorafenib. And these were the primary endpoints of this trial was progression-free survival and overall survival. And this is the updated efficacy data from this IM Brave 150, where we did see that yes, there was improvement in the median progression-free survival between the two arms. The comparator arm was sorafenib. So this was one of the very few trials where the comparator arm in hepatocellular carcinoma is another molecule that is being used for treatment. Because if we look at the other trials, we will generally find that in most of these hepatocellular carcinoma trials, the comparator arm is a placebo. So here it was sorafenib was the comparator arm, where we did find some improvement in median progression-free survival and some improvement in median overall survival too, and the hazard ratio being 0.66. So overall response was 30% to the immuno plus bev combination versus 11%, which has been the gold standard for all these years. And even the median duration of response was slightly better in the combination arm compared to the single agent sorafenib. And coming to the safety or the toxicity profile, uh, again, if we look at the toxicity profile, the immuno plus bev combination was much more tolerable and much more acceptable for the patients compared to the TK or sorafenib, which we have been using. So if the patient, although in this, as part of this trial, upper GI endoscopy was done within 6 months, repeated within 6 months of initiating treatment, and varices, if at all were there, were addressed according to the local standard of care. So what have been the key warnings and precautions or learnings from all these trials is Atizo, as like any other immunotherapy, a history of autoimmune disease and immune-mediated side effects we need to be aware of. And BEF, yes, GI perforations and uncontrolled hypertension and bleeding is something that we are really very wary about. So what do we do in our clinical practice? Which patient? So my first option, if cost is not a constraint, we not to forget the financial toxicity of such a morbid disease. So if cost is not a constraint and a patient is a PUC child a very well-preserved patient, which is generally not, we generally don't are not so lucky to have a very well-preserved patient. So if a patient is PUC child A, then I would prefer to give Atizo plus bevacizumab. Which patient is not a candidate for this? If a patient has had an history of transplant or an active autoimmune disease or any other condition that patient makes gives for which the patient is contraindicated for IO therapy. And yes, a patient with untreated esophageal varices, patient who comes with history of variceal bleed in the recent past or uncontrolled hypertension, these are the patients which I will not be considering for this combination. Coming to next, what other options I have? The other options in first line, the recommended options are both sorafenib and lenvatinib. And yes, both of them are recommended in PUC child A and sorafenib also in PUC child B category. So among the two agents, which is our agent of choice? So we have data, we have comparison now, enough data for comparison between the two molecules, both of them being multikinase inhibitors. Both lenvatinib having a slightly more emetogenic and fatigability compared to sorafenib. Both needs monitoring, both requires monitoring of blood pressure, thyroid function tests, and ECG, QT prolongation, and others. And this data basically comes for lenvatinib approval came from the REFLECT trial, which was more or less, which was more of a non-inferiority trial compared to sorafenib. Again, this trial also had the comparator arm was sorafenib, and the data for sorafenib came from the SHARP trial, where again the comparator arm was a placebo, as is the case in most of these trials. So the outcomes from the trial did show that since it was a non-inferiority trial, it did show that lenvatinib was non-inferior than sorafenib and for overall survival. However, if you look closely, the overall response to lenvatinib was much more, and almost the PFS response to lenvatinib was almost like doubling of PFS when lenvatinib was given compared to sorafenib. Although the primary endpoint was non-inferiority, which the trial did meet, And looking at the toxicity profile, we know that the two molecules, in spite of being TKI, is slightly different in the toxicity profile. Hand-foot syndrome, diarrhea, and rash was much more common with sorafenib if we just have a closer look. Hypertension, hypothyroidism, and proteinuria was more common with lenvatinib. So again, coming back to our clinical practice, what do I prefer, or what do we, most of the oncologists that I know, prefer? I generally prefer lenvatinib if a patient has a good performance, relatively better performance status. ICOG performance status 0 to 1. When less than 50% of the liver is occupied, no bile duct portal wave invasion, and the most important criteria, child poke A. And sorafenib may be better for a patient having a slightly worse performance and with significant liver involvement, and a child book probably A to B, and also with underlying chronic, if there is another major organ like chronic kidney disease or uncontrolled hypertension. So coming to the next option for first line, one of the recommended therapies is also nivolumab, and the data from nivolumab comes from Checkmate 459, which is again in another phase 3 trial, and where the comparator arm was again sorafenib, which has been the gold standard all these years. The primary endpoint for this trial was overall survival, and the secondary endpoint was again progression-free survival, overall response rate, and then correlation between PD-L1 expression and efficacy. So looking at the graphs, we again see that whether it is the progression-free survival or it is the overall survival, there was a little edge, not too much of edge, with immunotherapy compared to sorafenib. So the predefined threshold of statistical significance for overall survival with the IO was not met. Although nivolumab demonstrated clinical benefit, the overall response rate with the immunotherapy was much more, almost double than what we found with sorafenib, 15% versus 7%. So where are we now? Out of all the first line options, the recommended options, whether it is the IO plus BEV combination, or it is sorafenib or lenvatinib or nivolumab in a few cases, this is what the guidelines say, and this is what we generally do. So a patient with a very good performance status, child book A category, no varices, no active varices, no uncontrolled varices, blood pressure control with no contraindication for immunotherapy, and also no concerns for financial toxicity. Yes, atezo plus BEV is the regimen I generally prefer, but in the real world scenario, we generally end up giving more patients sorafenib or lenvatinib, because they are being more, what I'll say, pocket friendly to the patient compared to the IO plus BEV combination. And in special circumstances, yes, nivolumab may be given to a patient once if it is ineligible for a compromised with the child book B category. There are a lot of ongoing trials, there are a lot of emerging frontline therapies for this group of patients, where there seems to be role of dual checkpoint inhibitors, and also, as in with other cases, IO plus TKI, which seems to be evolving. So we have this LEAP trial, or the Himalaya trial, or the Cosmic, or the Checkmate 9DW, which is again double IO therapy, or we also have IO plus TKI like pembro and lenvatinib, and IO durvalumab plus tremelimumab, and these are something which have shown in whatever results we have, the data seems to be supporting the combination. And but before we really start following this practice, I think we need to wait for much more mature data. Coming to the second line options for this group of patients, advanced hepatocellular carcinoma, although it looks like many, and all of us know that there are hardly any second line options. Majority of these patients don't do that well. So since In most of these earlier studies, sorafenib was the only option. That was the first line option. And majority of the second line agents, whatever we have data available on the randomized control trial is post sorafenib, progression on sorafenib. Then yes, we have data for IO therapy. We have data for regorafenib, cabozantinib, and ramucirumab. And we really do not have our randomized control trial evidence for patients progressing on atezo plus bev in the second line. So what do we have? So we have multiple VEGF targeted therapies which may have activity after sorafenib. We have enough phase 3 data. So the data comes from the resource trial for regorafenib. Again, if we look, the comparator arm was a placebo. The curve seems to be well separated. There was some improvement in OS compared to placebo in the second line. So we also have evidence for cabozantinib in second or third line. And again, some improvement in OS, and the curve seems to be slightly separated, and some evidence for ramucirumab from the REACH2 trial. And although here a very important criteria was those patients who had an alpha fetoprotein levels more than equal to 400. So again, an improvement in OS compared to the comparator arm, and one can see the separation of curves. So what differs is generally the toxicity profile between rego or regorafenib or cabozantinib and ramucirumab, and we all know that watching for hypertension, for some LFT derangement, already compromised liver, and then watching for hand-foot syndrome. So coming to what is the option for a patient if the patient has received atezo plus bev for the first line therapy. So although we do not have randomized control phase 3 data, but we do have some data from the retrospective analysis of outcomes with all these wedge TKIs. So some retrospective analysis is there, and this is what this is from some of the few centers from Asian countries only, where the patient progressing on IO plus BEV combination, lenvatinib and sorafenib has been given. And here in the second line therapy, as far as PFS is concerned, lenvatinib seems to be scoring much more than sorafenib, almost 2 to 3 times advantage. But when it comes to the OS, the advantage doesn't seem to be that great. So again, yes, there is evidence of IO in the second line. The comparator arm again being a placebo, pembrolizumab data coming from Keynote 240, both slight improvement in progression-free survival and overall survival, and especially in the Asian population. So putting Asian population put together, the improvement was slightly more than what we found in the Western population. So again, what do the guidelines recommend? So second line options we have, again, lenvatinib and sorafenib if not used for the first line. Then apart from that, regorafenib, cabozantinib and ramucirumab. Again, IO if not used for the first line, we have a combination, IO combination, and other pembro and nivo both improve for second lines also. How to choose the subsequent therapy will depend on what was used in the first line and what was the tolerance to the first line. It will also depend a lot on the child book scoring, alpha fetoprotein levels of the patient, the comorbidities, the performance status, and yes, definitely the financial considerations. So best first line, I would like to summarize by saying the best first line drug I generally prefer is a combination of atezo plus bev. Already having said that, if there are no considerations of financial toxicity and none of the contraindications for a IO therapy or a anti-angiogenesis therapy and controlled varices. If patient cannot afford this, then lenvatinib I generally prefer over sorafenib, mainly from the reflect data, especially if the patient has a high alpha fetoprotein levels or underlying hepatitis B reactive liver or a extrahepatic spread. Overall response rate from whatever data we have and the PFS advantage seems to be more for lenvatinib compared to sorafenib. In a patient who is really compromised with the child-pok B, then possibly I will use only sorafenib or single agent nivolumab. Selecting second line therapy, if I have used already IO in the first line, then definitely all my IO options are gone. I have very few agents. From the retrospective data, yes, I can still use lenvatinib or sorafenib, and again the preference comes to lenvatinib compared to sorafenib, or regorafenib and cabozantinib. However, if I have used the TKI in the first line, then I will definitely want to use. Then that will depend on how the patient has responded to the TKI. So in the first line, if the patient uses atezo plus bev, then the preferred second line is a TKI, len, sorafenib, regorafenib, cabozantinib. For patient who has used first line, either if I have used a TKI, lenvatinib or sorafenib, with a significant durable response, then possibly in the second line, I may reconsider the TKI like regorafenib or cabozantinib. However, if the patient was a non-responder or a short responder to first-line TKI, then I will definitely prefer immunotherapy. Hepatitis C reactive cabozantinib needs to be avoided. Data from Celestial study. Alpha-fetoprotein high ramucirumab becomes the preferred choice in the second-line therapy. In a patient with child-pok compromised B, then possibly nivolumab or cabozantinib in the second-line therapy. So that's all for today, and thank you so much. I hope I finished in time.
You presented so nicely, ma'am, and so crisply. I just wanted to have your slide set. You presented so nicely and beautifully, ma'am, like always. Thank you very much, ma'am. That was really a wonderful presentation.
Thank you.
I don't think there are any questions from the ma'am. Our next talk is by Dr. Prasad Narayan. Dr. Prasad Narayan, sir, are you there? Hello.
Sorry.
The host, organizer, is Dr. Prasad Narayan there?
Hello. Yes, sir. Prashant Narayan sir has not joined yet. So
Okay.
just we'll try once and then we'll get that. So Dr. Prasad will join in next 4 minutes.
Okay. So Dr. Prasad Narayan is a senior consultant and director medical oncology, working at Center for Advanced Cancer and Immunotherapy, Site Care Hospital, Bangalore. And he will be talking on Cyramza, clinical evidence in second-line metastatic gastric cancer with case-based discussion. So we will wait for him. Ma'am, in the meantime, I may ask you, ma'am, how many of your patients are able to afford atezo plus bev? Even if we try, we are not able to give to anyone till now. Either patients are like bad varices or financial constraints are there.
Dr. Sumit, I could not hear you. Can you please repeat the question?
Ma'am, in our practice, we are hardly able to use atezo bev. Either it is the financial constraints which like we are not able to get, or otherwise patients who are affordable, they have bad varices. So what is your experience like at atezo plus bev, personally speaking?
So again, it is almost the same. I mean, ultimately, either the patient doesn't meet the clinical criteria, they have bleeding varices, they have esophageal varices, or they cannot afford.
Correct,
So I can actually count on my fingers. I've given it to only 3 patients, out
Okay,
of which 2 have done well and still doing well, and 1 did not do well in spite of giving this. I mean, whenever we as medical oncologists become conscious, very conscious when we are giving something I'll say such a costly combination for
That's
such
why I
a fatal
wanted to know,
disease.
is it worth that thing? Or Dr. Prasad is there. Good evening, Dr. Prasad.
In clinical practice, most of us end up giving sorafenib or lenvatinib.
Correct. I think, ma'am, the people who have the money, they end up burning their liver more by alcohol. So by the time they come to us, they got the varices and all.
But I don't know whether it is your observation also. Nowadays, we are seeing lot many hepatocellular
Correct,
carcinoma in the
correct, right,
absence
ma'am.
of hepatitis, in the absence of even alcoholic liver disease.
Correct,
Like
ma'am.
non-cirrhotic portal
Yes,
fibrosis mainly to do with this metabolic syndrome.
correct, ma'am. I agree, ma'am. Even of late, there is a lot of patients who are coming in, young, old. It was not so last few years back, 2 years back, it was not that much of incident that we see.
Yeah.
Thank you,
Sir,
ma'am.
I think Prasad Narayan sir has joined.
Okay. So, Dr. Prasad, good evening and welcome. So, next session is sponsor session by Libby, and Dr. Prasad Narayan is there. Dr. Prasad Narayan is working as Senior Consultant Director Medical Oncology at Center for Advanced Cancer and Immunotherapy at Sidecare Hospital, Bengaluru. And Dr. Prasad will be speaking on Sirenza, clinical evidence in second line metastatic gastric cancer. Over to you, Dr. Prasad.
Thank you, sir. Thanks for that kind introduction. Can I have the slides, please? So thanks for this opportunity. Unlike the real meetings where if it's a last topic, I mean, you will not have audience, but since it's a virtual meeting, we still have audience for this. So my topic is to discuss about gastric cancer. And we all know that gastric cancer is one of the most difficult cancers to treat. So we will see what, based on a case, whether, I mean, what have we achieved and what is the present status of treatment of metastatic gastric cancer. Next slide, please. Next slide, please. These are the disclaimers. Next slide. Next slide, please. So this is a typical presentation, a gastric cancer patient, 71-year-old male who has hypertension, hyperlipidemia, and upper GI endoscopy showed a tumor at the gastroesophageal junction. Biopsy showed adenocarcinoma. No metastasis, moderately differentiated adenocarcinoma, T3N0. HER2 was negative. No adjuvant therapy was given after surgery for this patient. Next slide, please. So after almost 2 years, this patient is coming with suspicious pleural metastasis, good performance status. This time the HER2 is done. First time it was 1+, but this time it is 3+. We will not go into the details of that. So this, maybe it was a lab to lab variation or a change in the biology of the tumor. Next slide, please. Next slide. So that is the recurrent disease which we are seeing here. Next slide. So the PET scan is showing a recurrent disease. Next slide, please. So as the standard treatment, I think we all agree that we would try to give this patient a combination of platinum with 5-FU or cisplatin, capecitabine, trastuzumab. This was the choice for this patient. The other patient would have, the other choice would have been in the present scenario, pembrolizumab plus trastuzumab or a Xelox 5-FU cisplatin treatment, or any other protocol, which sometimes we will give a triplet regimen also. This patient is in good performance status. Next slide, please. So this is the recommendation. The category 1 recommendation in gastric cancer is to give a fluoropyrimidine analog with oxaliplatin and nivolumab in patients who have a PD-L1 score of more than 5, or a combination of, if it is only chemotherapy, it's a doublet which is recommended. Is in G junction also, the present recommendation includes immunotherapy in as a category 1 recommendation. PD-L1 score is important in choosing immunotherapy. So the point to be driven is that in terms of chemotherapy, a doublet chemotherapy is what recommended, and in the present scenario, immunotherapy has come in a big way in the first line treatment. Next slide, please. So this patient was started on Folfox and trastuzumab. I think that is what most of us practice in our first line therapy. So after 6 months of treatment, the patient had a fall in ejection fraction, 71-year-old gentleman. So trastuzumab was stopped for this patient. Patient had portal vein thrombosis. He had to be given low molecular weight heparin for the same, grade 2 neurotoxicity of Folfox. So typical patient, this is what happens when we give 6 months of Folfox to many of our patients. Next slide, please. Next slide. So good response, almost a very good response for this patient. Next slide, please. So there the patient was kept under observation after that. So after that, in 6 months time, there is progression of disease. We can see in this PET scan about the progression. Next slide, please. So do we do a rebiopsy? In this patient, interestingly, there was a HER2/neu change which happened from the primary to the metastasis. Do we continue trastuzumab and change the chemotherapy, which sometimes we do in breast cancer? Do we start immune checkpoint inhibitors here? Is there a role of lapatinib or TDM1 in second line? I don't think, we all know that the data doesn't support that. And then the option of giving ramucirumab plus paclitaxel, which is the standard of care in second line treatment of metastatic gastric cancer. Now the newer data with trastuzumab deruxtecan, single agent chemo. So it is wonderful that now we have multiple treatment options in advanced gastric cancer patient post first line therapy, depending upon the patient's performance score and the profile of the tumor. Next slide, please. So this is the trial. We all know about the Rainbow trial, the landmark paper which established ramucirumab paclitaxel as the standard of care in second line advanced gastric GE junction cancers. Next slide, please. So this was the study design, very simple, straightforward study design, placebo versus ramucirumab along with the weekly paclitaxel. Next slide, please. So next slide. So these are the inclusion criteria. And well-balanced study. The baseline characteristics are balanced on both sides. Next slide, please. So this is the data, impressive data. The patient, the primary endpoint, the overall survival was improved by significant p-value, 9.6 versus 7.4, curve separating well at that point. So for in second line gastric cancer, an improvement by this percentage is really significant. And 1 year survival in second line patients was 40%. So that is how this established ramucirumab as the standard of care in second line along with chemotherapy. Next slide, please. So there is no group which did not improve. There is nothing to choose here. All the groups actually in this subgroups actually benefited by addition of ramucirumab. Next slide, please. Secondary endpoint PFS. Again, significant improvement in PFS. 9 month the progression-free survival was 22% in the ramucirumab arm. Next slide, please. Again, all the subgroups benefited. Next slide. So if you take the overall response rates, there was a partial response in 27% of the patients with ramucirumab and stable disease in 52. That gives a disease control of almost 79%, which is excellent in second line disease, second line gastric cancer treatment. Next slide, please. So side effect profile, I think we all know it's a safe drug. Next slide. Nothing more. There was nothing to say that it is adding more toxicity as compared to the chemotherapy alone. Next slide, please. Can I have next slide? So the trial concluded statistically significant and clinically meaningful overall survival benefit of more than 2 months and risk reduction of disease progression or death by 37%. Significant benefits in PFS and overall response rates were observed. Next slide, please. So second line, if you see the recommendation, there is no second thought that a category 1 recommendation goes for a combination of ramucirumab and paclitaxel in both gastric and GE junction tumors. There are other options, irinotecan and single agent. Ramucirumab as a single agent is also approved based on a randomized controlled trial in patients who are not fit for chemotherapy, or other chemotherapy options are also there. Next slide, please. So the patient got paclitaxel ramucirumab. He could finish 6 cycles of this. So with neuropathy, it is commendable that the patient could get another 6 cycles of 6 months almost of paclitaxel. He did not want to continue. Next slide, please. So again, next slide. So a patient had a disease control for almost 3 months without treatment. Next slide. So this time the disease has progressed and there is brain metastasis. Next slide, please. So palliative brain radiation, best supportive care. I think that once the patient of gastric cancer has progressed after 2 lines of therapy with brain metastasis, we may go for palliative brain radiation and best supportive care. Next slide, please. So that is the case, and the point to be driven was the first line option should be chosen, keeping in mind that most of the patients will progress, and we need to keep something for second line for these patients. And ramucirumab remains the standard of care in patients who progress on first line platinum and 5FU based chemotherapy in metastatic gastric and gastroesophageal junction. Thanks a lot.
Thank you, Dr. Prasad. That was very nice, small and crisp presentation.
Thank you, sir.
Yeah, Dr. Prasad, just query, just want, suppose like in second line, we can combine it with paclitaxel and give it.
Sir, your voice, I can't hear well, sir. Your voice is...
So we can use it in second line along with paclitaxel, right?
Yes, sir.
Suppose we are not able to give it in the second line, can we combine it with irinotecan in the third line?
Yeah, sir, in practice, we are using with irinotecan, but that is an off-label discussion.
Yeah,
actually.
correct.
Right.
Yeah, but that happens often because
Yes.
initially the patient, they do not want the expensive drugs, but later on when there is progression, they want to go, sometimes they want to go all out.
Right, right.
Then there is this dilemma, whether we combine it with there because evidence says second line, but we do combine it with irinotecan or polpid sometimes.
Yes, sir. I think in practice, we all use it.
Yeah, okay. And that was very nice presentation.
Thank you, sir. Thanks.
Thank you very much.
Thanks.
So any questions for Dr. Prasad? If there are none, I think we will wind up here.
Thank you.
Thank you very much, Dr. Minwalya ma'am, Dr. Prasad Rai, Dr. Sachin, and all those who are present here. Over to the host for the conclusion.
Thank you so much. Thank you everyone for joining and making this academic phase 2 wonderful. And hope everyone joins tomorrow also at the same time. Till then, good night. Bye.
Good night. Bye. Thank you.
Good night. Thank you. Thank you.